All right, welcome back to this afternoon's budget hearing with the Department of Human Services. Before we begin, we're going to go to the secretary who has answers to questions that were posed during the first half of the budget hearing. So, Madam Secretary, you want to go ahead and provide those answers?
Thank you, Mr. Chairman. I just wanted to follow up on two, I thought, really important questions about our SNAP program. One of the questions was the accountability standards that we hold authorized representatives to in that program. So if an individual is unable to, say, go to the grocery store on their own, they can authorize a representative to take their EBT card and go to the store on their behalf. And the reason that we didn't have it right at the tip of our tongues was because since 2022, which is before any of us got here, DHS voluntarily updated their procedures so that the authorized representative has to sign the same set of accountability standards that the actual recipient of SNAP has to sign. And so we will follow up with OSIG because if the folks at OSIG don't realize perhaps that they're able to investigate an authorized rep in the same way that they would investigate a SNAP recipient, we will make sure that they know that. And then the second question was a very completely appropriate question about education in our SNAP program. And we voluntarily opt in to a federal opportunity to provide education. In fiscal year 23, we don't have 24 numbers yet, we spent, invested really, $29 million of federal funds to educate SNAP recipients, and in that 1 year, we reached 650,000 of our about 2 million SNAP recipients with education about healthy eating, healthy food choices, healthy preparation of food, and things like that. So I just wanted to share those results. So if Chairman, if you could make sure those representatives. Yeah, thank you very much. I appreciate that. Thank you, Mr. Chairman.
Thank you, Secretary. We're going to start with Representative Webster.
Thank you, Chairman. And Secretary Kush, good to see you right here and have a moment to ask, and I'm kind of all over the place, so I'm going to talk a little bit about maybe workforce and reimbursement rates. I'll start sort of with a statement. Like other colleagues here, I'm an advocate for nurses. I know it's a workforce issue, and school nurses and other parts of, you know, whether it's the Department of Corrections and other places, but workforce and nurses across the board is an issue. School-based health centers. Can you just take a second and talk about what we're doing to increase our nurses and incentivize that career field?
Yeah, sure. So obviously nurses are integral to so much of the care that gets provided to Pennsylvanians in every corner of our Commonwealth. And I was extremely pleased to see the governor's budget recommendations to increase the amount of funding available for loan repayment, particularly for nurses and physicians that work in some of our more underserved communities. And also there's an additional funding line proposed that would incentivize folks into primary care, which is very much where we see many of our nurses. We are very strong proponents of a number of our school-based programs. We work with entities on school-based access program. We have our school-based health centers, and then there's also the school assistance programs, which can connect students to services outside of schools. Yep. And then, of course, through all of our home and community-based services, we support caregivers, you know, sort of up and down the certification and licensure range, but they're integral to everything we do at DHS.
And clearly, like, so just a quick change of subjects, and because obviously that's in all different sectors of your work and our government. But so let's, for the short amount of time we have, switch early learning real quickly, an increase that the governor's put into the budget. How does that really translate to wages and workforce in that arena?
Yeah, that's a great question, Representative. So the governor's proposed a $10 million increase to early learning providers who, And I want to make sure that that is distinct from our pre-K counts, also another very important group. But the early intervention providers are doing the work that really has been shown with lots of evidence to pay off for a lifetime. If a child has a speech issue, a learning issue, a behavior issue, a physical motor behavioral issue, that early intervention is where it really pays off. Sometimes issues can be nipped in the bud relatively easily, and that has a lifetime impact for that child.
Right.
The funding in this sector has been slow to increase. The needs have increased a lot, and so we're very hopeful that this $10 million increase for early intervention rates will be supported by the General Assembly.
Yeah. Thank you. And it looks like I still have a moment, so switch to some of our larger sort of overarching reimbursement rates. You know, home and community-based services, adult services, home visiting, personal assistance services, nursing, those things. How do we continue to make all that work? And I'm sure some of that's related to whether there's federal funding or not, but how does that play out?
Yeah, but putting aside the federal funding questions, it's extremely important that we honor the wishes of our older adults and individuals with disabilities to live in their communities of choice, which is almost always at home or some home-like setting. And in order for that to happen, we need people to be able to come into those homes and provide that essential care. In this year's budget, the governor's proposing an increase for our direct care workers that participate or that are part of the participant-directed direct care workforce. And that's very important because those are the workers that the individual participant is able to hire and direct themselves. And so that means that the participant gets the hours of care, the days of the week, all those things that really are important for them. They're able to direct that themselves.
It does seem, if I have this right, that while we're focused on direct care workers, we've left out some other categories that there's maybe something that we should be doing to highlight that.
Yeah, always happy to discuss that. And of course, the governor has also proposed an increase in the minimum wage to $15 an hour. And that is so long overdue. Right. And would have a huge impact on our child care providers. We still have many individuals who work in child care that are not making $15 an hour.
Right. Thank you. And I'm waiting for, the red light didn't come on, but it's right there. Thanks. Thanks, Mr. Chairman.
Thank the gentleman, Representative Mattson.
Good afternoon, Secretary. Thank you for you and your team for being here. And really appreciated your folks coming out to celebrate Sunbucks and beautiful Reservoir Park in my district. So thank you for that. My first question actually sort of piggyback off the previous gentleman's comments. Personal care services are essential for individuals that require them to live safely in their homes and communities. Can you explain what DHS has done to address the workforce challenges for personal assistance services?
Sure. So I'm going to put them into sort of two buckets. I'm going to start very quickly with some of the work that we did last year in the governor's budget for direct support professionals that work with individuals with intellectual disabilities and autism. There was, approved by all of you, a historic investment in those services, and as a result of that, the provider organizations that connect DSPs with clients have seen an increase in the number of workers available, and they have the lowest vacancy rate, which is 14%, that they've had in a number of years. So we do know that when these investments are made, they actually translate in the real world to more workers providing care, and of course that's what we need. In this year's budget, the governor is proposing to increase rates for the direct care workers in the participant-directed program. That is a program that primarily serves people with physical disabilities, not necessarily intellectual disabilities, but who need those personal assistance services to stay in their home. And the focus is on the participant-directed workers because, as I mentioned a minute ago, those are workers hired directly by the person, so the actual participant gets the kind of hours and flexibility and shifts that they want. And then those workers don't work for an agency, they work for the participant. And as a consequence of that, they don't have access to a provider or an employer-provided health insurance plan. They don't have access to an employer-provided paid time off system. And so this increase in wages to them will allow for some personal time off. It will allow them to hopefully be able to go onto Penny and purchase a health insurance plan that's affordable for them. And that money, that increase will really, almost in its entirety, go directly into their pockets.
Thank you for that. A follow-up question. The 2025-26 budget proposes investing in increased wages for certain direct care workers. Can you help us understand the differences between participant direction services and care through an agency?
Yeah. So as I just alluded to a little bit, direct care workers that work for an agency are working for an employer. So they work for the agency, that's their employer. In participant directed, the employer is actually the individual receiving services. So there, again, a lot more flexibility in that system. That individual can hire a trusted family member or friend if they wish in that program. They can choose the person that's providing their care. With the agency model, there's not quite as much flexibility for the participant. The participant may not be able to get quite the shifts that they want, or necessarily the exact person that they want. And as I mentioned also, if that person working for an agency is working for a larger agency, they may have access to things like health insurance or paid time off, which the individuals in participant directed don't have access to.
One final question. Can you explain why DHS only proposes to increase the MA rates for the participant direction services? How much of a percentage rate increase for these programs is it? How will they increase to rates, increase wages of direct care workers?
Yeah. So the goal this year, or the focus this year, was on those participant-directed workers. And even, with just the 8,500 people that would be in that particular program, the cost to the state is in the $21 million, and then would be a total of about $40 million going to those workers. The cost to do something similar for the entirety of workers that is in the agency model is on the order of $800 million. It's a dramatic difference. There are many, many more individuals that work for agencies than are a part of the participant-directed system. So just looking at a lot of budget realities before us, this decision was made to focus on this particular group at this juncture for all those reasons that I outlined, and but always, of course, open if the General Assembly wishes to further that in some way to talking about including others.
Thank you so much.
Thank the gentleman. Representative Young.
Good afternoon, everybody. Happy Women's History Month. I am loving the optics in the front of the room. Wanted to put that out there. My question is really around like the 911 call centers. It's a much needed and much utilized entity that focuses on crisis and suicide. This is a huge impact on the people in the Commonwealth. Can you tell me what can happen to those providers if the federal funds are removed?
Yeah, well, so thank you for lifting up our 988. I think do you mean 911 or 988?
988.
Okay.
Teamwork makes the dream work. Thank you for
Yeah, I wasn't sure I heard you right. So our 988 call centers have been a real success story here in the Commonwealth. We currently have 12 of them, and we are about to have 2 more that open, or are about to open, I should say. And what is great about where we're at today is that we are now answering over 90% of the calls from Pennsylvanians right here in Pennsylvania. We've got the capacity to take those calls right here, which is a great step. It's also really important to know that about 85% of the people that call, the issue that they're called about is handled right there on the phone. That means that person doesn't call 911, right, and have any police involvement. It means that they don't show up in an emergency department. They get whatever help they need right there on the phone. And then, of course, we've also been able to build out our mobile crisis response. There is some level of mobile crisis response available now in every county, not necessarily 24/7, but we're building in that direction. We've made a lot of headway. So these are all things that are very important to that crisis continuum, the goal being that people get the help they need where and when they need it, and reduce unneeded emergency room visits or police involvement. Neither of those systems are really trained to address these issues. Right now, 988 does receive federal grant funding from SAMHSA, the federal entity that works on substance abuse and mental health services. The governor has proposed a very important $10 million for 988 to make sure that we keep the funding here stable and that it can continue to grow. There are particular services within 988 that we would use these $10 million to expand. One in particular is our text chat service. More and more people are texting 988 rather than calling. And we're having a hard time keeping up with the text responses, so some of the dollars would go to that. And then very importantly, for our counties, some of these dollars would go to increase the interoperability between that 911 system and the 988 system. The counties have to run 911. It's an enormous expense for the counties. And so anything that we can do to help offload some of that responsibility and increase that interoperability between the two so that calls can just be directed over appropriately to 988, that would be not only a win for the person, but a win for our counties as well. So this $10 million would be used in some very needed ways.
I love that. Thank you so much for that. Can you touch on how those non-English speaking people can also gain access? Do you have language barriers? How are you addressing those needs?
We do have language services on 988. We have access to language line, and we have, in some cases, people who are multilingual. So we try to make sure that everybody can get the help that they need in the language that they're most comfortable speaking in.
So you have how many languages, language access services do you provide?
So with the language line, I think language line provides access to virtually, most languages.
Nice.
Yeah.
Thank you so much.
I don't know the exact number, but it's many.
No, I just wanted to make sure it wasn't just the normal one or two.
Oh,
right?
no. It's very broad.
Awesome. Thank you so much.
Yep.
Thank the gentlelady. Representative Brennan.
Thank you, Chair. Thank you all for being here. And following up on some of Rep. Young's questions on emergency mental health services, I had a question about the crisis walk-in centers. Bucks County is working on a great project, public-private partnership between Lenape Foundation, Doylestown Health, our local hospital in the county. I'm wondering, how is the anticipated funds going to be spent? Have we had an idea on that? Is it for new facilities? Is it to support the existing facilities?
Yeah. So in this year's budget, the governor's proposing to continue a $5 million increase from last year for crisis walk-in centers or crisis stabilization centers. And again, just to put that into that continuum that I was just speaking of, so it starts with somewhere to call, which is 988, someone to respond, which is that mobile crisis team potentially, and then somewhere to go. And these crisis stabilization centers are short-term stay types of locations where an individual can be assessed and then, warm handoff over to what next treatment is appropriate for them. And so the $5 million that was allocated or appropriated last year has been, or is going to, counties that don't have a crisis walk-in center right now, and they are actually getting ready to open 5 new ones. They'll probably all be opening this year. And then in this year's budget, there's a continuation of those dollars. But I do want to point out that county base funds, which is also part of the governor's budget, which is to allocate an additional $20 million to county base funds, counties have the flexibility of using some of those county mental health base dollars toward crisis services.
Understood. And this is a question. In the course of proposing a registry to identify people who have abused somebody with a disability, I saw some of the problems that the Bureau of Hearing and Appeals are having, getting through a tremendous amount of work that they have. I saw it a little bit as a private attorney doing Act 534 cases for corrections officers and mental health nurses. I'm wondering, do we need more judges there? It seems as if that they're having a hard time getting through what they have, although they're doing wonderful work. There seems to be a legislative desire to handle some of these registries. We've seen it with Childline as well. And I have to think that we're going to have to anticipate a problem from the federal government cutting SNAP and Medicaid and creating even more burdens for an already burdened office. So I'm wondering if you can tell me a little bit about, and this is a crucial thing for people to have due process hearings, to have what they're entitled to constitutionally. So I'm wondering if you could speak to that and what your feelings are regarding the staffing there.
Yeah, I'd be happy to do that. Thank you for the question. So our Bureau of Hearings and Appeals does an incredible job. They hear thousands and thousands of cases every single year. And we're in and let me just be clear that the enormity of what they hear. They hear child line cases, they hear Medicaid appeals, they hear reduction in services appeals for personal assistance services. I mean, it just runs the gamut. So the short answer to your question is, could we use some more judges? We could, and in fact, part of our complement request is an effort to replace some individuals that are currently contracted employees in our Bureau of Hearing Appeals with permanent Commonwealth employees. And so that is part of addressing some of that need. But I do have to also point out that there is ongoing litigation, and I can't get into the specifics of the litigation, but depending on how that litigation is resolved in Commonwealth Court, it has the potential to lead to an enormous increase in the need for full hearings, particularly for individuals who are facing charges of child abuse, who've been reported to Child Line. So we're in a little bit of an uncertainty period here at BHA. Depending on how that litigation ultimately ends up, we potentially could need significantly more personnel there.
And one last question. I had some constituents reach out to me about Keystone First that are running businesses, and they're reporting delays and issues with approvals. I know there was an auditor, an inspector general audit at some point. What are we doing to oversee the MCOs, and is there anything you can tell me on that specific issue?
Yeah, sure. I mean, certainly, if you hear from a constituent about a specific issue with one of our Medicaid MCOs, let us know right away. We are on top of those folks quickly when we hear, especially, particular complaint that we can act on. But just generally speaking, they have many contractual obligations for how quickly they provide services, how quickly they pay bills, all those types of things. So if there's any problem that your constituents are having, you should just let us know.
Thank you, Chair, and thank you for being here.
Thank the gentleman. Chairman Heffley.
Thank you, Chairman, and thank you, Madam Secretary, for being here today. There's a number of reports that DHS must submit to the General Assembly. Can you provide a list of all the statutorily required reports and the last date that they were submitted? An example, the child fatality reports required as an act from 2006. But is there a list of those reports and when they're due and when they're sent to the General Assembly?
I am certain that list exists. I do not have it in front of me today, but we can certainly get it to you.
Okay, I appreciate that.
I sign off on those reports regularly, so I know they're coming over all the time, but I don't have the complete list in front of me.
Thank you. The proposed regulations were issued regarding the psychiatric residential treatment facilities, primarily for adolescents. Chairman Warren and I sent a letter to IRC expressing concerns about these regulations. In their comments, IRC suggested that DHS continue to advance notice, DHS issue an advance notice or final rulemaking to engage the stakeholders and reach a consensus. Does DHS intend to issue that advance notice? And what is the proposed timeline and process for the issuance of those final regulations?
So are you talking about the psychiatric rehabilitation regulations? Oh.
It's the psychiatric residential treatment facilities.
Yes. You know what? I'm going to ask Deputy Smith to come up. She has the specifics on that.
Sure. Thanks, Chairman Heffley. We received quite a number of comments as a result of that initial publication through IRC for the PRTF regs. So we've been spending the last month or so sort of really combing through all of those comments, beginning to engage in stakeholder conversations. We'll be having another series of webinars with stakeholders here coming up to hash out still some areas where there's real discrepancy with the stakeholder feedback we received. You know, some people feel really strongly there should be more of something, and another group feels really strongly there should be less. So trying to reconcile some of those issues. We still do intend to get the final form regulations submitted to IRC during calendar year 2025, but I don't have a specific time frame because we really want to make sure we address some of the questions and concerns that were raised by you as well as some other stakeholders.
Yeah, I mean, obviously we hear from constituents. I can tell you that a lot of my colleagues have talked through our committee about issues where we have adolescents that are looking for these services and they can't find the services. There's definitely a shortage. So making sure that the providers and working with that the provider network to ensure that they can be compliant is really important. So, there's no push to say get these regulations out by summer of 2025.
Right. We want to do it right.
Okay. And just as a follow-up to Representative Ecker's question regarding the performance-based contracting, how can we assure families that have complex medical or behavioral health issues and are receiving services from the residential providers that they will continue to receive those services when their provider is not credentialed as a select or clinically enhanced provider? And how many providers have been credentialed in the top tier in the first submission? I think you said were there any at all that were credentialed in the top tier?
Yeah, I'll have Deputy Secretary Ahrens come up and address the specific numbers. But again, I just want to reiterate what I said this morning, which is that this is not an effort to kick people out or be punitive in any way. This is an effort to make sure that this incredibly vulnerable population, you know, many of whom don't necessarily use words to communicate in other ways to express if they've had problems, gets high quality care. And we are looking to actually build the whole system up for exactly the people you mentioned, those with the most complex needs. This program will incentivize these providers to take on these most difficult cases in a way that we have not been able to incentivize them before, really I should say compensate them before.
So in the first round, we had 36 providers submit for their tier determination. 20 of those requested tier determinations for select or clinically enhanced. Letters went out last week to 5 of those providers who have now, so of 20, 5 of them did make it as select or clinically enhanced. We are currently in another data submission period for providers. We have 65 applications as of this morning that we are working through. I'm very confident we will have a number of select and clinically enhanced providers that come out of that. One of the really key things that we can't lose sight of with performance-based contracting is, thanks to the appropriations for this program, there has been a really significant investment in building provider capacity. Specifically, there are additional funds for clinically enhanced and select providers to accommodate the fact that we are requiring a higher level of clinical support for individuals in those services. There's also pay for performance. We've got about $40 million that's available for capacity building for the provider community to support them with meeting the new standards with performance-based contracting.
Thank you, and I see the time's out, but it is important. We have a segment of the population which needs these very specific types of services, and we want to make sure that providers have all the tools that they need, especially with the closure of the state hospitals. We're seeing folks that are really struggling to find those services, so thank you for your time.
We agree with you.
Thank you, gentlemen. Chairman Williams.
Chairman, thank you. And Madam Secretary, thank you and your team for being here this afternoon. One of the department's initiatives is to provide pre-release medical assistance coverage for reentrants and continuous eligibility after incarceration. And this initiative is a critical step towards preventing healthcare gaps that have historically contributed to high rates of overdose, recidivism, and poor health outcomes. Would you talk a little bit about how those reentering benefit from the 30 days of medication upon release?
Sure, thank you, Mr. Chairman. So this is, you're referencing our 1115 waiver, which is one of the programs that was approved in late 2024 by the outgoing administration. and it allows us to use our Medicaid dollars in new and different ways that we have not been able to use them for previously. This flexibility that we've been allowed would bring in 90% of the costs covered by federal dollars. The state would cover 10%. And it would allow us to partner with the Department of Corrections, who has been able to reduce recidivism over the last few years, but we still see well over 50% of individuals in Pennsylvania who leave one of our SCIs recidivate. So this would be a partnership with DOC. It would allow our teams to go in 90 days prior to release and begin to work with a set of individuals. We would prioritize individuals with serious mental illness, a substance use disorder, or a serious chronic disease, or someone who's pregnant or recently given birth. And we estimate around 7,000 people or so would be assisted. They'd walk out the door with doctor's appointments, with medication in their hands, a primary care doctor identified for them, and 1 year of coverage in Medicaid. And this is extremely important. We know this helps reduce overdose deaths. We know that it helps individuals stay out of the emergency department, because if they're not connected to care, they're just going to go to an emergency department, which is not helpful to the emergency department or the individual for the long term. And so it is a much more holistic way of setting these folks up for success. We want them to return to their communities, be able to get jobs, get back on their feet, and be contributing members to their community.
Thank you. Listen, how will the services they need be continued in the community?
So the plan would be that there would be what we call warm handoffs. So for the folks that are involved with them while they're still incarcerated, needs would be identified, doctors would be identified, case management folks would be there for them once they were released. And because they have that 1 year coverage of Medicaid, they would be eligible for case management, be able to see doctors, all those pieces would continue. They would have prescription medications covered, so they'd walk out with 30 days, but then they'd be able to get those prescriptions renewed.
Madam Secretary, thank you. Chairman, thank you.
Thank the gentleman. Chairwoman Clonk.
Thank you, Mr. Chair, and thank you, Secretary, for you and your staff being here today. In my new role as our Republican Chair of the Children and Youth Committee, I've had a chance to meet with some of our psychiatric residential treatment facilities. So I would like to confirm with the department that those regulations that Chairman Heffley had spoken about, you do not intend to do any rollout until the fall later this year, so not this summer like originally stated?
Yeah. Let me get you an update on that, and congratulations on your new chairmanship.
Hello?
There you go.
Hey. So for those less familiar with the process, the regulations that were already put out for public comment was just sort of the initial version of those regulations. Then you receive all the public comment, and then before they can become officially promulgated regulations, they have to go again through that process and be put before the IRC, and then there has to be a vote. So we're at that point right now between those two submissions to the IRC. So we can't effectuate any change until the final form regulations are submitted and approved. So we're working through all of the comments that came in. There was a significant amount of stakeholder feedback. We want to make sure that we've sufficiently addressed all of that before we're submitting the final form regulations for vote. So
we're not expecting summer, you're expecting more fall based on your previous comment?
Yeah, I believe it'll be in the second half of the calendar year is probably a much more realistic time frame.
Okay, thank you, because I would love to be able to report back to these organizations. Madam Secretary, the governor recently proposed a budget that would include $55 million for child care recruitment and retention payments. Can you answer this yes or no? Are those payments intended to be one-time payments only?
That is my understanding.
Okay, thank you. Will the funding be for full-time staff or full-time and part-time staff?
The funding is intended at this juncture for teachers and teaching assistants. I'm not aware that there is a requirement to be full-time to go with that, but if you're a teacher or a teaching assistant at one of of a child care provider that is a participant in Child Care Works, that is a definite stipulation. I don't think the amount of hours that you work is related to that.
Okay, so then additionally for the requirements, would there be a length of time that you have to be employed with that particular organization to be eligible to receive that benefit?
I don't know that it's been decided at that level of detail, and we're certainly open to working with all of you if you have thoughts on that. I think the intent of these dollars is to kind of do both. So the goal is both retention and recruitment. And so if someone were a relatively new employee, and they were to get, say, if they were a full-time employee, got that $1,000, maybe that is also considered part of recruitment and retention for somebody that's relatively new. So I don't know that the distinction in this particular workforce space is that distinct.
Okay, would there be a requirement for an individual who receives this one-time payment to commit to a certain number of months of working after receiving that particular payment?
Yeah, I don't think, we just haven't gotten into that level of detail either. And again, that is something that we can absolutely discuss with you. If you go ahead and approve these dollars, we're open to getting your input on what that looks like.
Okay, and I appreciate that that you're willing to talk about it, because I've been on, my listening tour out with my child care facilities, and one thing that they've shared with me, because I asked them, do you think that this would actually help with your retention and recruitment? And they said, actually, no. They said, we need regulatory reform and we need changes in the regulatory space to let us do what we do best in helping educate and take care of our children, and some of the regulations just are in the way, especially when it comes to training staff, and especially creating a pipeline for a pre-apprentice or an apprentice, those high school age children, soon to be young adults, who could be transitioned into that workspace. So
if I could just jump in there real quick.
But one quick thing. So they also don't believe that those one-time payments are going to help, because we've seen it before in the pandemic, and we just didn't have the individuals stay. So do you have hard data that shows that giving these individuals these one-time payments will actually result in retention? Where is that data?
So I've actually spent a lot of time visiting child care providers myself all over the state, and I have heard something different. I have heard that they think it would really help to get people, to help people feel appreciated. Even if it is a one-time payment, it's an acknowledgement of how hard these individuals are working and would actually help. Also, the governor has proposed an increase in the minimum wage to $15, and we have accounted for that in our budget in our child care space. We have many child care providers who are not making even $15 an hour, and that may be the bigger piece of this. So I think those two things together, the minimum wage increase and these recruitment and retention bonuses, would go a long way to helping these child care providers. I also just want to clarify that there are definitely entry-level positions under current regulations that don't require a college degree. There seems to be a little bit of a disconnect there. Now, if you're going to be a supervisor, you do need higher degree requirements. But there are entry-level positions right now today in our current regs that allow people to come into childcare without a college degree. That's the biggest complaint that I've heard.
And thank you, Secretary. I look forward to working with you on this, and maybe we can continue this conversation to help our child care industry. Thank you.
Thank the gentlelady. Chairwoman Mann.
Thank you, Chairman. Good afternoon, Secretary and staff. I'd like to first commend you on the progress on the studying of 988 and 911 interoperability and all the progress you're making with text and answering phone calls and the mobile mental health crisis unit. That was originally a resolution that I proposed in 2023 after the tragic death of Christian Hall, a young man who was considering suicide and called 911 and then ended up being shot by the state police. So that we're making all that progress is incredible, and I thank you so much for all that work. I'd like to talk to you and switch over to the LIFE program, something that's near and dear to my heart, and I hear often from stakeholders and our senior citizens what a wonderful program it is because of its holistic approach of care coordination and preventative care. However, it seems to be one of our best-kept secrets. When we talk about it, it seems most people hear about CHC, community health choices, and not about life. So moving forward in the Aging Our Way plan, how do you propose to really highlight the LIFE program and give it an opportunity for people to explore and understand what it is? And I'm a little biased, as my husband is a musician, has been playing at Life Geisinger for over 10 years. And at Christmas time, I bake cookies because I sing really badly. And you just see the love, and you see the community, and you see just how wonderful it is and how people feel like they're being cared for. So we'd really like to promote it and love to know what you're doing to that end.
Yeah, thank you for that question. I really appreciate it. And I share your commitment and enthusiasm around our life providers. They really do a great job. So I'm right there with you. And we have been aware for the last couple of years that the life providers, to some degree, think that their programs are not being as promoted as some of the other programs. And so we have worked closely with them. We have worked collaboratively to increase the independent enrollment broker referrals. And I just take it back one step. There's an independent enrollment broker that people go through. And the job of the IEB is to present people with all of their options. And so we have substantially increased the information that we have. We've actually worked with the life providers to give them information to make sure it's getting out accurately. And we also send an annual letter to CHC participants to let them know that life is an option. And that has increased their enrollment about 4 to 5% per year as we do that. So, we've been working pretty closely on this issue to make sure that information is getting out accurately. We still don't have every county participating in life. And, that may be part of some of the challenge for the independent enrollment brokers, is that not every county has it. And so they have to be very mindful of, who they're talking to where. But if you have ideas, we're very open to understanding what more we could do to make sure that they feel like they're getting a fair shake at that very first stage with that independent enrollment broker.
Well, we are planning an upcoming informational hearing about the LIFE program versus CHC, so I look forward to sharing more ideas and information at that time. Thank you so much. Thank you, Chairman.
Thank the gentlelady. Round 2. Representative Kincaid.
Thank you, Mr. Chairman. Thank you, Secretary. It's been a marathon and not a sprint for you. I'm wondering, I want to talk a little bit about the rape crisis line item. It's been flat funded again for the 5th year, and we're looking at increased costs to our rape crisis centers by 28%. And an increase in overall demand for services. Can you explain why that was flat funded again this year?
Yes, I do appreciate the question, and I very much appreciate the need. And as you know, this is an extremely tight budget year, and there were a lot of extraordinarily difficult decisions that had to be made. We are working very hard to make as many accommodations available. There's a lot more availability now of the telehealth exams so that an individual can go, almost anywhere at this point and via telehealth get a trained sexual abuse evaluation, by someone who's trained to do those evaluations and things like that. But unfortunately, that was not something that was slotted for increased funding this year in the governor's budget.
Thank you. We've talked a little bit about, SNAP and other food insecurity programs. I want to talk a little bit about Sunbucks. I know that there has been some issues with the rollout initially, the kind of difficulty of folks accessing it because they were in CEP schools, but they it was no longer universal for those folks. But I'm wondering if you can talk about how Sunbucks is going to work moving forward.
Yeah. Well, first of all, I just have to give a shout out to my team, because in 6 months, with just 6 months' notice, they stood up this program that helped put $120 into the food budgets for the families of 1.2 million kids last summer. That is extraordinary, and they did it in 6 months. And believe me, it was not easy. And part of the challenge, of course, remains, getting all the information that we need about the eligible children from the many, many school districts that we have in the Commonwealth. So just want to give a shout out to them, because it was like around 24/7, around the clock kind of work to get that stood up. But we're really, really proud of that work. And we will be continuing the program. It is 100% federally funded, and we will be able to roll out those benefits earlier in the summer this year, because obviously we are not standing it up from scratch this year, so we're looking forward to that. And are there other specific questions that you have about it, or?
No, I just wanted to kind of highlight that, and yes, that it was a short turnaround, but that we're continuing.
And obviously I know you know, but not to put too fine a point on it, it's the summer where so many food insecure kids really struggle, because they don't, under our governor's leadership, they all have free breakfast. Everybody has free breakfast, and many children have a no-cost lunch as well. And then summertime comes, and that all ends. We all know, we have incredible schools and charitable organizations that do summer backpack programs and things like that, but it's not the same. And so Sunbucks really helps to fill a gap in that summertime food need.
I'm going to pivot to one more topic. Do you have a time frame for creating a Medicaid payment mechanism or a state plan amendment for community health workers?
I wish I had an easy answer to that question. So we are big fans of community health workers. Myself, my whole team here at DHS, we right now have it required through our managed care organizations that they need to provide certain services in the communities and use community health workers to provide those services. So it is absolutely the case right now that community health workers can be hired through our Medicaid MCO programs and do the incredible work that they do in our communities. We've been working very closely with the community health workers. They would like to find a path to be enrolled as providers within Medicaid, as doctors and psychiatrists and dentists and many others are. That has turned out to be quite complicated for a whole variety of reasons that we probably don't have time to go into today. But my team had multiple listening sessions with them, I think 8 in November and December, and then are starting now with some smaller group, more intensive meetings to try to really delineate a scope of services. The way that I would like you to think about this is Medicaid is very old at this point, right? Back to the 60s. And it was created in a very hierarchical system of doctors writing orders for very specific services for patients in hospitals mostly. We've evolved to a very different kind of program that's much more holistic, much more community-based, and much more preventive, working on those upstream issues to try to keep people healthy in the first place. And we are working mightily to put these sort of, I'm going to say non-traditional, but extremely important providers into this system, and it's not built for them. And so it's hard. And we've been making slow but steady progress with doulas, with certified peer specialists. We are still, to some degree, struggling with certified recovery specialists, and we're struggling with community health workers for a whole variety of technical reasons. So we're committed, but bear with us as we try to make this program fit into 21st century care that it was not designed for.
Thank you. Thank you, Mr. Chairman.
Thank the gentlelady. Representative Flood.
Thank you, Chairman. Madam Secretary, I have a real quick question, and then I have something deeper that I want to follow into. But I just wanted to go back to a previous question that I had regarding the intellectual disability waiting list. As you previously stated, I understand that you're managing the waiver capacity by the amount budgeted, not necessarily by slots. Per se. There has been a 19% reduction in the waiting list up to this point. But specifically, how many individuals, not slots, how many individuals do you believe will be served and removed from the waiting list for fiscal year 25-26? Your program measures do not indicate serving additional individuals.
Actually, they do, and I know, and I'm not being disrespectful. So right now, and again, this is where I was saying earlier, we have to all together move away from that sort of slot mentality, more to a budget mentality. And over time, people come in and out, people pass away, things change for people. And so when a person passes away, there's funding then available for somebody else. Before we would have said there was a slot, but now we're thinking of it as actual funding. And we are making maximum use of the dollars with this new approach, because that way, if a person doesn't need that full gamut of services on day one, they can get what they need, and we can use additional dollars to help someone else. So we might actually get 2 people services where before, under the slot system, we could only help 1. And so just right now today, we still have waiver capacity of 41,555, and we have just over 40,000 enrolled. So we know today we have additional capacity to fill and are working to fill that quickly through this year.
Okay, thank you.
Does that help? Does that?
Yeah, that helps.
It's a real, I know from being a county commissioner, it's a very big shift in thinking, because we always worked on slots, right?
Yeah.
But now we're working with the counties, and we're just Allegheny, I think, right, the first one to start. We're working with all the counties very closely to help them kind of change this mindset as well. It's not going to happen overnight. It's a big shift.
Yes.
But we think it's the answer.
Okay, thank you.
Yeah.
And it's my understanding also, Madam Secretary, I'm switching gears now, that there are programs in the Commonwealth, including through your department's youth development centers, to provide services to youth with sexual behavioral treatments needs. I had a young girl that had come into my office with her parents. She was 9 years old when she was raped. A few years later, she started cutting herself, self-harming, then followed the suicide attempts. She was recently diagnosed with intellectual disabilities. She was at a local children's home where, while she was there, was preyed upon by a worker who then raped her again. She's been told by qualified mental health doctors that she needs to be in a residential treatment facility. Why does Pennsylvania have programs that treats boys but not girls for the complex problems that she has? And this is what I've been told. When I've called out to your department and asking, how can we help this woman, or this girl, I should say, they said, well, we have programs for boys, but it doesn't apply for girls. And when I asked, why is that? They said, well, there just aren't enough girls for that type of program. I find that hard to believe. Maybe it's just that they're not being identified because there's that idea out there that there aren't programs available for them. But how do I explain this to this beautiful, now 16 years old little girl that's like, when I ask her, how is she doing? And the tears are running down her face because she can't understand what's happening to her. She has this hyper-sexualized ideation as well, which adds to the problem. And she doesn't know because she keeps trying to kill herself. What does her future look like when we, as a state, she's coming to us looking for help, and we say, we don't have a program for you, you're not the right gender? What does it need a legislative fix? What do we do?
So, first of all, I'm very sorry. I mean, it's heartbreaking to hear a story like that. And I would be happy to work with you and this individual. We have a whole team now that deals with children with complex needs, which obviously this child absolutely falls into. I don't know why you were told that. I'm certain that there's ways that we can try to help this girl. And if for some reason there's not, we can work to understand what we need to do to fix that. But we'd be happy to follow up with you. Obviously, we can't discuss the specifics here, but get you connected to that team and see if they can work with the family and the young woman to get her the help that she needs.
Well, her family has been huge advocates for trying to help her, and I know just at Christmas time, after meeting with her, she was hospitalized again for a suicide attempt. And I just think we can do better for our youth, and we can find ways to help. So I would love to work with you if afterwards we can talk about maybe how we can connect with your team.
Definitely.
So we can connect you
I
with
hope
the
we can
family.
help.
Thank you.
We should help. Yep.
Thank you.
Thank the gentlelady. Representative Khan.
Thank you, Chairman Harris. Thank you, Secretary Arkush. And in the governor's budget, I was really heartened to see that he included full practice authority for our nurse practitioners to be able to practice to the full extent of what they've been trained to. I'm the first nurse practitioner ever elected in this assembly, and really excited that we may be able to join the 30 other states in the District of Columbia as a state that allows nurse practitioners to stay and work to the full extent of their authority. Can you talk a little bit about the impact of this, what that would mean for access to care in urban and rural areas, having nurse practitioners be able to practice the full extent of their authority?
You know, honestly, I don't have specific data on it because that's really more of a Department of Health issue, I think, on some lens. But I mean, I think it's obvious to say that there would be increased accessibility. I think that in a time where we do have very severe shortages of practitioners, that when practitioners can work to the maximum abilities of their license, that's extremely important. So I would imagine that it would help.
Thank you. Thank you. We talked earlier about the proposed $880 billion in cuts to Medicaid, which would be just catastrophic to our communities. And under Medicaid, though, there is some flexibility of where money can go. And so currently, Pennsylvania is one of, I think, only 3 states in the nation that doesn't allow for assisted living, for that to be reimbursed under Medicaid. Can you talk, has there been, because I'm working across the aisle with Representative Marcel on a bill that would actually allow assisted living providers to be able to be reimbursed under Medicaid like 47 other states. Can you talk a little bit about the thought process of where DHS is on allowing that to occur, allowing assisted living to get reimbursed under Medicaid?
Yeah, so we are always trying to maximize the opportunities to live in the community for anyone who wants to do that. And obviously our assisted living facilities are part of that continuum. So I'm gonna get a little weedy on you here, so stay with me. So first of all, the term assisted living residence has different definitions in different states. And so I'm not trying to evade the question, I'm just saying, when you see one state's paying for assisted living residences, it might actually be something quite different than our, in Pennsylvania, assisted living residents. So that's just at the baseline. Federal dollars do not allow us to pay for room and board, hard stop. And that's been one of the sort of hang-ups, so to speak, at assisted living facilities who would love for us to pay for room and board. We could do that with state dollars. If the General Assembly wants to take that on as a full state cost, it is within your purview to do that, and we would pay it. In the meantime, we have all three now, the third one's about to start, of our CHC managed care organizations are running pilots. And those pilots provide what's called an in lieu of service. The service is a nursing home. So they are working with, 2 of them I think are up and running and the third's about to start, with a handful of assisted living residents who are willing and able to provide that nursing facility eligible level of care. And under that scenario, an MCO participant could choose to stay at an assisted living residence instead of going into a nursing facility as part of this pilot, in which case those services would be covered. But it is also the case right now that if somebody qualifies for home and community-based services, meaning that they have clinical conditions that would potentially make them, or would make them nursing facility eligible, they can stay at an ALR and pay room and board out of pocket, and then through this pilot, the MCOs can pay for that bundle of services that would allow them to stay there. So it's complicated, but we're working through it.
Thank you.
And there's not an easy solution to it without a lot of state dollars.
Well, I'm not in the yellow. I'll ask this last question. You can be just very brief if you can. The 1915 waiver, in terms of housing insecurity, I think some states have been looking at possibly using it to help with housing. So, because people obviously that don't have housing can't take their medication and they end up in the hospital. Any thought about possibly doing that in Pennsylvania?
Through CHC? Or the 1115 waiver.
Yeah, 1115, sorry, yeah.
Yeah, so absolutely. That was one of the component waivers that we had approved in December of 2024 by the Biden administration. And while we had hoped to start implementation in this budget cycle, this is part of this stepwise implementation.
All right,
So,
thank you so much.
yeah.
Thank you.
Thank the gentleman. Representative Alsumer.
Thank you, Mr. Chairman. And thank you again, Madam Secretary. I'd like to give a shout out to our Wayne County Commissioners and their team back home. In the very near future, they will be opening a new 24/7 mental health and crisis center with beds for short-term stays. This will have a significant impact on Wayne County and on the region surrounding, the community surrounding the region. The the center will have the ability to treat adults and children, which is a significant issue. It really will keep families from having to drive states or hundreds of miles at the very least to treat their children. Madam Secretary, the enacted fiscal year 24-25, the budget included funding for youth development and increased bed capacity. The program measures on page E27 through 40 of the governor's executive budget show a projected increase in youth served at contracted placements. Have the new beds, as a result of the enacted current year budget, not come online yet, or are there additional adjudicated youth in the system?
So there are youth. So if you look at the number of youth in our system over time, like let's go back 5, 6, 7 years ago. Actually, let's go back 10 years ago, kind of pre-Sandusky. The number of youth in the system is definitely down, which is great news. And the number of providers is way down for a whole variety of reasons. And it went down even further during COVID. And so we are in a position now, and I think you were here this morning, you heard a little bit about the issues coming out of some of the Southeast counties with increasing needs for youth to have beds. We don't have more youth in the system than we did 10 years ago. We have less, but we needed to increase the bed capacity. Those two things got out of whack. And so we got into a position where there were youth waiting in detention in many of the counties across the Commonwealth. We had, when we came in, when we got here in January of 2023, I think we had about 157 youth on a waiting list. They'd been adjudicated to secure treatment with the state, and we did not have a bed for them. Today, I think we have 27 people on that list. Yeah, 27 people on that list. And so the reason that we have gotten that down is because we've built more beds, and it was further compounded by the fact that a number of these youth are getting these time commitments. They now represent a significant percentage of our youth that are in secure detention with the state or secure treatment with the state. So it's been a multi-factor situation that we've been working very quickly to fix, but that waiting list is basically down to just a couple weeks, at this, maybe a month at this point, for someone to move into our care. And we've done that by increasing capacity a little bit.
Thank you. On page 62 of your department's budget materials, your operating budget reflects a decrease for the conclusion of the rite of passage Lake Granbury Youth Service Program and a decrease for the transportation contract. Can you provide information on this program?
Sure. So that was one of the short-term solutions that we implemented to relieve overcrowding and reduce that waiting list for some. It was overcrowding in Philly and waiting lists in many other counties. We sent a total of 16 youth to Texas. 15 of them completed their time there successfully. One did not because they were brought back here to face adult charges, so that wasn't a treatment failure. They just had to come back for further court proceedings. That program ended December of 2024 because this other capacity that I just described to you had opened. So we no longer need that contract and don't intend to restart it.
Okay, thank you. Are there similar programs still in operation?
Sending youth out of state or?
No, in state or out of state, for that matter. Are there still, do you still have any other, are there
we
similar programs
Yeah, we
for,
contract with a number of private providers as well.
are they
So-
out of state?
There's still some, are we all in state now? Yeah, entirely in state, yeah. And remember, judges decide where these youth go. It's not us. So judges in every county in the Commonwealth adjudicate youth, and they decide, is this youth going to come to a secure state treatment facility, or are they going to go to this particular facility? And they make those decisions for a variety of reasons, the needs of the youth, the proximity to family, all sorts of things. We contract with providers all over the state.
Okay. Thank you very much.
Yeah.
My time is
Thank you.
up. Thank you.
Thank the gentleman, Representative Waxman.
Thank you, Mr. Chairman. Thank you again. It's good to have you guys here. It's been a long day. I'm impressed by the stamina of you and your team. So, I just wanted to ask about the MCO assessment. And the first question that I have, we've touched on this in various ways throughout this hearing, but can you confirm that DHS is seeking a legislative reauthorization of the expiring MCO assessment? And if so, can you just kind of quickly describe how it's collected, what the rate is, how much has been connected over the years, and particularly if any of this funds have been returned, the assessment funds have been returned to Medicaid MCOs or private insurers over the years?
So let me give you a little bit of the kind of the background and the history of this, because it goes back many, many years. So in Pennsylvania, Medicaid is funded through state funds with additional funding from a series of assessments that are imposed on various healthcare entities. And that includes hospitals, nursing homes, and managed care organizations. The money that is received from these assessments is used to draw down additional federal funds. And assessment revenue is used to offset state funds that are required to support the Medicaid programs. And it ensures that low and no-income Pennsylvanians actually are able to access their medical care. Beginning in 2015, consistent with CMS federal rules with respect to how states could impose assessments on managed care organizations, the General Assembly passed legislation to authorize the current MCO assessment, and then the General Assembly reauthorized that in 2020. The assessment is collected through a per member per month assessment. As of January, that is $30.47. And we anticipate that that will add $2.3 billion for state fiscal year 25-26 to Medicaid funding. The assessment is up for reauthorization at the end of June. It actually expires. And so, of course, these things are always up to the General Assembly. If the General Assembly chose not to reauthorize the MCO assessment, then there would be
to get that review. What about the final part of my question about whether or not any of those assessment funds are returned to either MCOs, commercial insurers?
So the rate setting process, and we actually, hopefully you got this when you sat down, this actually goes through the annual rate setting process for MCOs. We gave everybody a handout because there's been a lot of questions about this, and it's pretty darn complicated. But if you look at the part that's called, non-benefit components, that is where Medicaid MCOs can account for all their operating costs, and it allows them to recognize taxes paid to the state. We don't regulate commercial insurance companies, so I can't speak for exactly how that works for private insurance companies, but I believe that private insurance carriers can account for operating costs such as taxes and assessments imposed on their commercial customers in their commercial rate filings, but that's really a question for PID to get clarity on that.
Okay.
So it's all part of the rates, and I think again, speaking on the Medicaid side, the way to think about it is that it comes back into the rates of these managed care organizations. Some years they might get a lot of it back. Some years they might not get it all back. There's no direct tie there. Rate setting is very complicated, and that is just one of the factors that goes into the rate of any particular MCO.
It is very complicated, and I appreciate you walking us through it. I guess what we have heard from some, certainly folks in my district, about concerns that this could lead to an increase in premiums. And I guess I'd be interested to hear your response to that, and if that's a valid concern.
I don't know that with certainty. It's certainly on the Medicaid side, the rate setting process is the process, and there are no premiums on the Medicaid side. If the concern is on the commercial side, I think how that is handled on the commercial side in terms of their accounting for that and their rates is a question that I don't have the expertise to answer.
Well, I see my time is running down, and so I appreciate your answers, and thank you very much, and thank you, Mr. Chairman.
Thank you, gentlemen. Representative Krupa.
Thank you, Mr. Chair. I would like to briefly, just to clarify the record, with respect to your answers to Representative Flood regarding intellectual disability services, and I'm referring specifically to E27-36 of the Governor's Executive Budget for 2025-2026. With respect to the numbers of persons receiving intellectual disability services, the estimated for 2024-25 is 59,379. The estimated for 2025-26 is 59,379. So there is no increase there. With respect to the mental health services and the forensic bed capacity, the Governor's executive budget includes several new initiatives on the mental health services line item appropriation, including $5.8 million for community-based programs to serve people who do not require the level of care provided in a state hospital or are being discharged from a university. First of all, can you tell me specifically what level of care that is? How many beds would this proposed funding support, and in which counties?
And I'm sorry, are you talking about the CHIPS beds or the forensic beds?
I'm speaking, I'll ask you that. So I'm referring to the new initiatives in your mental health services line appropriation of $5.8 million. So the community-based services that are to serve those who do not require the level of care provided in state hospitals or being discharged from an institution.
Let me get to that. Before I answer that, which I will, can you just correct on the ODP question?
Yeah, so you were referring to the program measures in the governor's executive budget. I do see that, and I believe it's simply an error, and we will work with the governor's office to correct the program
Okay,
measures.
so you can understand our confusion there. Thank you for acknowledging
Totally
the error.
understood. Thank you for pointing it out.
Thank you.
We'll get that corrected.
Thank you.
Okay, so back to the forensic beds. So as you know, we are committed and able to provide treatment for people who are involved in the criminal justice system so that they, if they are deemed not to be able to stand trial, that we can restore them to competency to stand trial. We are not always successful in that work.
And I'm from Fayette County, and there's a horror story from Fayette County in that particular fact pattern. An individual who was not fit to stand trial, but there was some type of absurd delay in him being deemed incapacitated. He was incarcerated for a significant period of time. I mean, I believe 2 years or more. And it was just one part of the system failed him after another part of the system after another part of the system.
So that is exactly the problem we're trying to fix.
Thank you.
So thank you for mentioning that. Yeah. So historically, from time to time, there have been very long waits for individuals who have been deemed not able to stand trial. They're still in their county correctional facility. I was a county commissioner, I know what this feels like. There was not a state hospital bed for them in our forensic division. And so what these forensic projects propose to do is to make sure that we can continue to move people to lower levels of care to make room for exactly the type of individual that you're speaking to. So if an individual is not able to ever stand trial, they're just deemed non-restorable in terms of competency, then we are trying to move them to a different setting, which could be an appropriate type of setting in a community. We have many counties that are doing these community options. And then that would open up the space for someone like what you talked about, so that that time in the county correctional facility is as short as possible.
So is the $5.8 million, is that all going to that particular program?
I have 5.75, yes. Okay. And with this funding, we would be able to create 26 additional slots, which is projected to serve 124 people annually.
Okay. And I have to say Representative Flood did a really heartfelt job of telling one specific person's story. I think almost every member here probably has a similar story, unfortunately, in their district. In the system, it should not take somebody reaching out to their state rep to reach out to you to get the assistance that they need. And it has a terrible trickle-down effect. I mean, not only do you have this individual in crisis, then you have hopefully a family that's also suffering through that crisis. It impacts our children and youth when they don't have an appropriate place to place a child in their care that has these issues. It's impacting, as you just noted, the legal system. And I mean, the juvenile beds is a terrible issue, but there's also an issue with the adult beds. So how quickly is the time frame to make sure that we get to a point? There should never be anybody in crisis that needs to be in a mental health facility. You know, I've heard horror stories of female juveniles that end up in a hospital bed in the ER for 10 days. Right. That should never happen.
So the issue of complex children has been here in the Commonwealth for years. I've been here for 2, but it has been an absolute priority of mine to fix it. We now have, as I mentioned, an entire team. I have someone on my executive team whose only job is to work with complex kids. And we've made significant progress. You may have heard about our Blueprint Working Group, which was a statewide effort to bring county-level folks, providers, all sorts of people together to come up with a strategic plan for how to fix this problem. We are going through the short-term, medium-term, long-term recommendations and starting to implement. One of the things that we've done is a Pediatric Capacity Building Institute. Last year, we had 35 participants from around the state. It starts again next week, and this year we have over 50. And what that is doing is it's giving people the skill set to work with these really complex kids. They're very much like the individual that the Representative Flood described, multiple, usually trauma, abuse, and then multiple other things that have come with it. We now have a total of 4 people on that team. We have regional heads. We are moving as quickly as we can so that you have someone, you know exactly who to call when something like this comes up, and we have a system to work with that child and hopefully get them the care that they need. I agree with you that this has been something that has been so difficult to deal with that folks have kind of done this with it because it's been tough. I'm not telling you I have all the answers yet, but we've made an enormous amount of progress in 2 years. Last year alone, this team, which wasn't even at full capacity, helped 250 kids get treatment resolution out of the ED into appropriate levels of care. So we are on it. I ask just a little bit of patience as we continue to build a system that just didn't exist before, frankly. And we love to work with you to help make it stronger.
Thank you. I see I'm out of time. Thank you for your testimony.
Thank you.
Thank the gentlelady. Representative Fleming.
Thank you, Chairman. Thanks again, Secretary. I want to commend the gentlelady from Lawrence County for talking this morning about the OLTL workforce, the Office of Long-Term Living workforce, and you illuminating the fact that 8,500 workers are going to get a rate increase. I just had some additional questions about that. Are CHC, OBRA waiver, and Act 150 programs included in that proposed rate increase?
Yes.
Okay.
If they're in participant directed.
Okay. 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 We're good on that?
That's a firm yes.
Excellent.
As long as they're in participant directed, yes.
Does the increase cover union and non-union attendance?
It would cover anybody in participant directed.
Okay, so
a direct
as long
care
as
worker in the participant directed model.
Okay.
So participant directed is a model.
Right.
So if you are a worker in that model, yes.
Okay. So it doesn't matter if you're organized, if you aren't.
Correct.
If you're in a participant-directed model, then you are subject to that rate increase. You should see that rate increase.
That is correct.
Wonderful. Okay. And then, do you know what the rate increase is by percentage?
I do not.
Okay. Okay. We'll try and get that answer. So that leads me to.
We do know. Hold on.
So right now on the fee schedule, it's around $15 an hour for participant-directed workers on average. So we'll move it to roughly $18 an hour. So it's like a 5% increase.
Okay, wonderful. Thank you, and happy birthday, Gloria.
Thank you.
So given the cost disparity in home-based care, well, let me ask a question first. I have heard from some providers in personal care homes that there are some disparities in terms of how those are paid for. I think we're one of very few states, and please correct me if I'm wrong, Secretary, but I believe we're one of few states that doesn't allow personal care homes or does not allow medical assistance to be a payer for personal care homes. Is that correct?
So this is kind of what I was getting into with, I think it was Representative Khan earlier.
Yeah.
We are not allowed to pay for room and board. That's a federal rule.
Okay.
If the General Assembly wished to allocate state dollars,
We could, in
we
fact,
could do that.
Okay.
Yes.
Okay. I would love
but to be clear, we would not be able to draw down federal participation for that. It would just be state dollars.
Okay. Well, how would that be? Would that be detrimental? Would it be an overall loss?
No, it would be. I mean, the issue is it becomes a trade-off for other programs.
Okay.
It would not be a trivial amount of money by any stretch of the imagination, and so it would just be a trade-off with other programs.
Okay. But I believe, and I'm happy to speak with the department a lot more about this, but I think it would be an enhancement to what we're doing now. And the reason why I think that is because the cost of keeping people in home-based or like personal care home settings is a lot more than skilled nursing. And so I think we can realize those savings on the back end if we can keep more adults out of skilled nursing and more in home-based care, which most consumers prefer.
So
that.
I know I'm kind of splitting hairs here, but just to be clear, folks that are in personal care homes and are choosing to live there, they are not generally nursing facility clinically eligible.
Right. But I'm saying,
and if they became eligible, then they would be eligible for, and they were in Medicaid, they would be eligible for home and community-based services to allow them to live in the community, not necessarily in that personal care home, depending upon how it's set up. But they could move to a different community setting where they could get home and community-based services that would be paid for by Medicaid, because you are correct, it is more cost-effective for them to stay in the community than go to a nursing facility.
Okay, yeah, thank you for that clarification. I'm just saying, like, and I saw this unfortunately with my father. Like, he was able to stay in his home, but his condition did degrade because he didn't have access to a higher level of care, just being in his home. And so one last quick thing. I want to thank and commend the department for meeting and greatly overcoming the challenge of the Medicaid and continuous coverage unwinding. I know you all spent a great deal of time trying to make sure that folks didn't fall off the rolls, but I am hearing issues about Compass, issues of delays, extended downtimes, freezing screens, et cetera. Wait times have now gone from like 5 minutes to up to 30 or more minutes. What is the department doing to try to get its hands around the issues with Compass? And I know I'm running out of time, so if
I'll make it really quick.
Okay.
So we have been working on a Compass modernization program, and one of the things that we've done is we made the Compass website fully mobile, because we know most people have handheld devices, not laptops. So we're really working to meet our clients where they are.
Okay.
In the course of some of these upgrades, we have absolutely run into some glitches, unfortunately. One of them turned out to be a login issue from a certain operating system on a certain device.
Gotcha.
And it took us a long time to figure out that that's what the problem was. We have since fixed that.
Wonderful.
So I think most of what your constituents are seeing hopefully is getting better, or has gotten better already.
Well, that's wonderful. Thank you, Secretary. Thank you, Chairman.
Thank you, gentleman. Representative Nelson.
Thank you, Mr. Chair. We're going to pick up our questions, and I appreciate you staying for the afternoon. In that area,
Did I have a choice?
yes. In the area of able-bodied workers without dependents, which is its own subclass. Westmoreland County, we have an enormous need for workers, and I do appreciate. I want to make sure that I'm saying it correctly, the work of the department and Deputy Secretary Fahm in trying to help us engage or re-engage some of these folks. In the morning session, you had mentioned that it was maybe going back as far as 2009, and that the federal government has guidelines to apply. Trying to build on that a little bit. This is an article that was earlier this year on MSN, Pennsylvania's job market defies odds. Unemployment holds steady at record low amid shocking labor force changes. The article goes on to say, our longest streak of lowest unemployment since 1976. But we're still waiving the work requirements for able-bodied workers without dependents. So not with kids, not with caregiver adults. Can you touch on why?
Yeah. So, Representative, I asked that question myself because it did not make sense to me. And as I dug into this, what I came to understand is that, ironically, let me first talk about who these folks are. Most of these folks are individuals with barriers to employment. You know, they may not have a they may not have a high school diploma. They may have other issues. We know that at least 35% of them have a diagnosis that makes it difficult for them to work, like serious mental illness and a substance use disorder or cancer, getting chemotherapy. I mean, that's 35% of our able-bodied adults. They're still in that category.
Individuals that would have, and I know we're really limited on time.
Let me finish. I'm sorry. Let me finish.
We're really limited on time. So
when there's a very tight job market and employers have their pick of candidates, these individuals are not going to be at the top of the list.
But respectfully, Madam Secretary, there is not a tight job market. We are desperate for workers. And even if you say 35% of those workers may have issues, that's 70% of those workers that could get re-engaged. It doesn't matter to Westmoreland County if they have a high school degree or not. What matters is re-engaging them. And those folks, 90% of them are receiving medical assistance at a cost of $30 million a year in taxpayer funds. So if you said that year over year, we're waiving these work requirements for people we need in our hospitals, in our nursing homes, in our factories, I mean, that's $150 million we're spending. At the same time, we have 3,700 people on a waiting list of our most needed individuals with disabilities. It just seems like we are protecting one group at the expense of another.
Well, remember, SNAP dollars, the SNAP money that these individuals receive is 100% federal funds.
Yes.
It's not impacting any of those other state dollars.
But the Medicare medical assistance dollars are state dollars.
Right, but many of our Medicaid recipients are working. I mean, these folks might very likely get jobs that did not make enough money to get them
Madam Secretary,
away
this
from
is
Medicaid.
160,000 able-bodied workers without dependents, 70% of which, as we move forward, it would be really good to get these folks. I mean, I'm a father of 7. Sometimes you got to be encouraging to get them off the couch.
Representative, I just want to be clear that those waivers that we know go back to at least 2009 didn't necessarily apply statewide that whole time. They were in regions where there were these very strict federal requirements for these waivers. We anticipate that the statewide waiver we will no longer qualify for as of this May. It's very likely.
Great
now,
to
there
hear.
will still be regions in the state that may qualify.
I'm going to pivot. I only have 30 seconds left.
All right.
I'd like to pivot to the concerns that we have, growing concerns with our MCOs and our community health choices. Specifically, in 2020, we were serving 380,000. This is coming from the Office of Long-Term Living's database. We had 380,000 folks for $3.3 billion. In 2024, the number rose to 385,000, but we're now at 5.8 billion. And this year it's 6.7 billion. So that's like 4,000 more people at almost double the cost. How much profit are these MCOs generating?
Not much. So let me tell you what's happening. The population is aging, as you know. We are having more and more people that are over age 65, and they are living longer, and as they live longer, their needs increase. Where we're seeing the majority of that increase in community health choices is in those personal assistance services. And so we're seeing that someone that maybe last year only needed, 10 hours a week, this year needs 20 or 25. As you know, this is a workforce that's been extremely difficult for our providers to recruit. They are needing to pay higher wages. the acuity of the services that a lot of these folks need are escalating as they age. It is still more cost-effective to keep these folks in the community than it would be in a nursing facility. Remember, the alternative is that these folks go into a nursing facility. It's not like there's a nothing. It's nursing facility or community, and it is still more cost-effective, even with the increasing costs of medications and workforce and all those things for these individuals to stay in the community.
Great, I see I'm out of time. We just want to make sure those dollars are making it to the facilities of the workers.
Absolutely, yeah. You can ask any of the MCOs about how we negotiate rates with them, and as I've said to people, I'm not going to get this congeniality from any of the managed care MCOs. So we negotiate very hard with them.
Thank you, Mr. Chair.
Thank the gentleman. Representative Abney.
Thank you, Chairman Harris. Madam Secretary, I want to talk a little bit about the homelessness assistance program. In last year's budget, I think we increased this funding $5 million, and in the proposed budget, it looks to maintain that level of increase. And so I wanted to see if you could tell us a little bit about what counties are able to use that funding for and what some of the programs that the counties are actually doing around homelessness assistance.
Yeah, we were extremely grateful for those dollars. That was the first time that the Homeless Assistance Program had seen an increase in a number of years. And I just lost my page here, Representative, I'm sorry.
No problem.
Here we go. So the program funds emergency shelters, rental assistance, including eviction prevention, and also rehousing individuals. It provides case management. It can provide bridge housing for someone that's moving from one place, one situation to another, that sort of intermediate housing, and a number of other services. So the most recent year that I have full data for is 23-24, but we just built on this data, last year, and we'll have more to report next year. In state fiscal year 23-24, we provided 59,355 individuals with emergency shelter, rental assistance, case management, bridge or transitional housing, and additional services. That translates into 353,839 bed nights of emergency shelter to 11,009 unhoused Pennsylvanians. So that kind of gives you a sense of the scope of some of this work. Rental assistance went to 11,505 Pennsylvanians to prevent evictions and to help with a security deposit or first month's rent for someone who was being rehoused. And then we provided case management services to 32,042 clients, and 1,571 received bridge or transitional housing support.
And this was all data pre the $5 million increase?
So this is 23-24. We just don't have, unfortunately, we didn't have it in time for this. But that additional funding will allow us to increase all of the services, which are desperately needed.
And when do you think we'll have the data for?
So we'll have, hopefully, by June, we should be able to share some additional updates on that.
That'd be great.
For the last,
That'd be great. Awesome. Wanted to talk also a little bit about, I know DHS is now allowing medical providers to bill for services provided to individuals who are living on the streets. Can you talk about how this new effort in street medicine helps to address the healthcare needs of homeless individuals?
Yeah, sure. Thank you for raising that question, Representative. It's something that we're really proud of. We have created the opportunity for a site of service to be the street or the park or a corner. A typical site of service would be a doctor's office or a clinic or a hospital, and now the street, anywhere on the street really, can be a site of service. And this is so important because physicians and nurses and medical students and dentists and midwives and all sorts of people for years have gone out as volunteers and cared for individuals who are unhoused, but now they can be paid for. And this care is extremely important. This care allows these providers to build relationships with individuals with the goal of getting them into a safer space, to encourage them into treatment if they have a substance use disorder or a serious mental illness. And it's building those trusted relationships that is often able to get someone to agree to be helped. It goes a long way to doing everything from providing vaccines, making sure people have naloxone, providing very simple dental care and other care. It helps to keep people out of emergency departments where we know our emergency departments are busy enough. So it is a huge success, and we're now seeing that since it's being paid for, if the individual is Medicaid enrolled, which most of them are, the vast majority of unhoused people are in Medicaid, and if they're not, they're probably eligible, and so folks can enroll them. What we're seeing now is that more and more hospitals and other provider groups are starting street medicine teams because now they can get some reimbursement for it. So it's just a win-win all the way around.
Got you. Thank you, and thank you for the work that you're doing, your department as well. Thank you, Mr. Chairman. Appreciate it.
Oh, thank you, gentlemen. Representative Marcel.
Thank you, Mr. Chairman, and thank you so much for coming back this afternoon to answer more questions with us. I wanted to ask a little bit about performance-based contracting. We've been hearing concerns from providers of home and community-based intellectual and developmental services regarding ODP's transition to performance-based contracting. Last year, this administration prioritized these services by recommending increases to their funding. Now it seems contradictory to be increasing the regulatory and financial burden on these providers as well as ODP through the implementation of performance-based contracting requirements. Specifically, under current regulations, providers already have 2 oversight inspections: quality assurance and improvement, and the annual licensing survey. They also have monthly monitoring visits with supports coordination organization. Performance-based contracting adds a 3rd annual recertification or requalification inspection. And so I have a few questions about that. So one is, who's actually doing these assessments through the performance-based contracting?
So while Deputy Secretary Ahrens comes up, let me just say, and we've talked about this a number of times today, the goal here is to raise the quality of care for the most vulnerable group of Pennsylvanians that I can think of, that we are paying for that care with taxpayer dollars. And I think that taxpayers deserve to make sure that their dollars are being well spent and providing high-quality care for this very vulnerable population, a population who isn't necessarily able to communicate when something has gone poorly for them. The goal with performance-based contracting is to give providers incentives to do better so that we're paying for quality, not quantity. We have some enormously complex individuals living in the community, and we want it to be that way. We want to make sure that everybody who wants to live in the community gets to live in the community. We need our providers to step up and meet that need, and this is how we're able to both incentivize and then subsequently compensate them for taking on some of these much more difficult cases and build the capacity we need to treat this entire community. And the Deputy Secretary can give you more of those details.
Thank you.
Yeah, so a couple of clarifications. One, the rate increases that went into place July 1 of 2024 were for all ODP services. So that was for all home and community-based services, not just residential. For residential, there was additional funding that was in the appropriation that is specifically to support the implementation of performance-based contracting. So that includes rate add-ons for 2 of the 4 performance tiers, and that includes a significant amount of funding for pay-for-performance, which at this stage is all aimed at supporting providers with capacity building. In terms of the regulatory oversight, you're correct. This is an incredibly highly regulated industry for the reasons that the Secretary cited. So our residential providers are subject to both program regulatory oversight and to licensing regulatory oversight. One of the things, and that's all compliance, that is straight compliance. That does not get us to outcome-based payment, that doesn't get us to quality outcomes. That's what we want to do with performance-based contracting. For the high performers, we believe that we will be able to pull back some of the other regulatory oversight.
So when would that potentially be? Because I think streamlining, like I was reading articles about performance-based contracting, and basically they talked about the perversion of incentives and that you have all these unnecessary duplicative steps. And while you're trying, of course, like everyone wants to be helping this population, like everyone agrees on that. But at a certain point, you know, there's a need to streamline and potentially just make it a little bit easier.
And we don't disagree. Our hypothesis with performance-based contracting is for providers that can meet those higher performance standards, those quality standards, we believe that we'll be able to start seeing this in a year, that we will have evidence that says that we don't need to do our oversight, our regulatory oversight in the same way for those providers, that we will be able to lessen that. So I think after a year's data.
I know the yellow light's on, so I just wanted to mention that. I'd love to know, since you're saying it's a year away, like if we can get a sense of what the cost is annually to conduct all of these inspections separately. So if it's going to take a year for us to potentially streamline, is there a way to see how much it's costing to do all those levels, and in the hopes that we can eventually streamline it and make it a little bit more, you know, a little more efficient?
Great. Thank the gentlelady. Representative Mullins.
Thank you, Mr. Chairman, and Madam Secretary for hanging in there with us for a second round. As we've discussed at length regarding this recent rate study of the Office of Long-Term Living and Home and Community-Based Services programs, along with Act 150, the last rate review or study was in 2014. What efforts could you speak to that DHS is making to ensure that your agency is doing a more regularly scheduled rate review for these home care programs, say every 3 years? It's similar to what's done with ODP, home community-based services programs.
Well, I agree that, actually, honestly, I'm not certain when the last full formal rate study was done, but I can tell you that in 2022, we had an 8% increase in personal assistance services. So that was the last time.
Okay.
And then now, 2 years later, we did this formal rate study, and which has been published, and you can certainly take a look, and we're happy to answer any questions that you have about it. The numbers are substantial. Mm-hmm. And that is why, facing a very, very tight budget year, the governor made the decision to focus the increase on the 8,500 direct care workers in the participant-directed model, knowing that those dollars will basically entirely go into those workers' pockets and allow them some supports for some personal time off if they wish to take it, and also hopefully make insurance a little more affordable for them to purchase, neither of which they get because they don't work for an agency.
Gotcha. Well, thanks for the clarification. I appreciate it. Thank you.
Thank the gentleman. Representative Brown.
Thank you, Chairman. Madam Secretary, you spoke earlier about our aging population, and they're living longer, and their needs are increasing because of that, which we all know. So as it relates to that, the behavioral health MCOs received a mid-year rate adjustment of 4% in 2024 to offset losses that were seen across the state. But I continue to hear from constituents that this isn't enough to sufficiently meet the services needed across the state, even with the increase that you've proposed in the budget. So I understand that higher acuity after the pandemic has been a national trend, but are you confident that your actuary has appropriately projected the needs of this program moving forward?
We are. Again, I'll point to my handout here that should be at your desk that shows you the robust rate setting process that has gone through with our actuary to determine rates each year. Once those rates are determined by the actuary, then we enter into a negotiation period with the managed care organizations, and then ultimately rates are signed off on. In the behavioral health space, there's not full renegotiations every single year. There's contract adjustments and then full rate negotiations every so many years. But we've seen as you know, increased growth in the underlying costs that these providers are facing, and we know that, right? Workforce is more expensive. There's increased utilization of services. I think maybe one of the good things from the pandemic is people are much more comfortable acknowledging that they may have a behavioral health issue and seek help for it. So that is increased utilization of these services, which in the long run is a good thing.
But how do you ensure
And we
that?
are increasing rates by 8.2% this year. So we will implement and we will do what we do every year, which is continue to monitor. As you saw in 2024, we did do a mid-year rate adjustment. I'm not in any way saying we're going to do that this year. That was pretty extraordinary what we did last year, but I cite it as evidence of the fact that we are keeping very, very close eye on how all of our primary contractors are doing throughout the year.
And how do you ensure that those increases are going toward patient services?
So the increases go to the primary contractors, and that can be a county, an individual county, or group of counties. Those counties contract with a managed care organization. So when I was county commissioner in Montgomery County, we would put it out for bid every couple years. We contracted with Magellan, and then the county negotiates those rates with that managed care organization for services in that county. Those counties should know better than anybody what they need in terms of services in their counties.
So can you then share the percentage of allocated funding per behavioral health MCO that is spent on care? Do you know what that would be?
I don't know if we, I don't believe, I think we can try to get through that. I don't know if we have that exact number or not.
Do you monitor statistics like that?
I will tell you that they would be held, like any insurance company, to the medical loss ratio. So it has to be at least 85% of every dollar has to go to patient care, or they have to refund money. I mean, that's an Affordable Care Act requirement.
If you're able to forward those on to us, that would be helpful.
Yeah, if we have them, we can.
Yeah, and I think if you refer back again to the annual capitation rate setting document, you'll see that non-benefit load or non-benefit component, that's sort of the pieces that are not the direct services to patients. So it's part of rate setting, it's an allowable cost. But I think what you're asking is just specifically how much of what calendar year rate that component is?
Yes,
Okay,
correct.
just want to make sure we understood.
Okay, thank you. Thank you for being here.
Yeah.
Thank the gentlelady, Representative Siegel.
Thank you, Chairman, and thank you, Secretary Arcus, for continuing to be with us. I want to start on the subject of Medicaid because I think it's experienced a tremendous amount of scrutiny today, and I just want to try to lay out some of the facts and figures. So I think all too often in the federal discussion, there are two ways that policymakers like to stipulate that we can find savings without taking away benefits from beneficiaries. And the first one they always talk about, frankly, is the work requirement component. And to my knowledge, only one state in the country has ever actually imposed broad unilateral work requirements. I think it was Arkansas, and it was disastrous.
They tried.
Tried, and then a court struck it down. 1 in 4 beneficiaries lost access to that health care. 95% of the folks that were subjected to that work requirement actually were determined to have been eligible for some sort of a waiver anyway because they were caring for someone. Can you just talk a little bit about the fact that I think it's 2/3 of folks on Medicaid are currently engaged in work, and then the vast majority of folks have some reasonable excuse. Talk about the danger of a work requirement as it relates to making sure people actually get access to good care.
Yeah, we haven't done any analysis on this year because we don't know what any proposal is going to be. And I'm not going to ask my staff to spend hours and hours of time.
Just broadly speaking.
Hypotheticals, but we do have some information from back in 2018 when work requirements were proposed under the first Trump administration. And the conclusion of this team at the time was that we would have to hire several hundred new workers to oversee and implement this kind of supervision that would be required to actually determine how many hours somebody was working, and that the cost of the administration of this program, and this is why actually Arkansas and Georgia both tried and gave up, the cost was so much greater than, and I use this word reluctantly, savings of someone who's forced to disenroll from Medicaid didn't even begin to add up. And just remember, that individual now who doesn't have access to health care will have a heart attack or will be in a car accident through no fault of their own, have to go to a hospital, and now a hospital will have to treat someone in an emergency, they're required by law to do that, with no way to be compensated for their care. So the fallout is way beyond what it's going to cost DHS. It is what it means for our entire system of care.
So to be clear, it seems that you would get an expanded bureaucracy, right? The state of Pennsylvania would have to hire hundreds of new individuals, creating a mountain of Byzantine paperwork, right? We're going to force working people to go through more and more hurdles to get access to critical care, and many of those folks are going to wind up being determined to be eligible for some sort of waiver anyway, because as we've seen in other states, we're only just making people jump through hoops that they shouldn't have to jump through anyway. And then the other articulated sort of savings they always talk about, and Speaker Johnson has said a lot about this, is the improper payments, so to speak. And I believe that the National Health and Human Services determines that Medicaid's improper payments is about 5%, but nearly 3/4 of that was simply recorded as improper documentation. I believe that's accurate. So I think, could you just comment a little bit about, at least at our level, that improper documentation more often just means that, maybe a form wasn't collected or some information was omitted, but it does not mean that the corresponding payment was unlawful or should not have been provided, correct?
Right. Yeah, I think you heard me speak earlier about the incredible work that our Bureau of Program Integrity does on cost avoidance, and it's over $400 million of cost avoidance. But that gets counted as, in some of these calculations, as potential improper payment. That's money that was never spent in the first place if it was cost avoidance. And so there is this narrative going around in Washington that they can save $880 billion over 10 years by reducing waste, fraud, and abuse. It's a fantasy. It's just an absolute fantasy. What this will mean is that fewer people in Pennsylvania will have access to health care. Those that do have access to health care will have fewer benefits. Those individuals and their families will pay the price, and so will our hospitals, who have no room to take on any more uncompensated care. It'll be a disaster for our Commonwealth.
I thank you, and I share your sentiment that the mathematics being thrown around in D.C. is nothing more than delusional arithmetic, and all it's going to wind up doing is adversely affecting the most vulnerable parts of our population. As we said, 2/3 of these folks are working. They're doing everything right. They just simply don't make enough to be able to afford health insurance, and they certainly don't get it through their employer. So they're relying on a lot of this. This is the only way they can get access to critical prescription drugs, pre-screening, making sure that they don't fall into worse health. And so I think it's a win for society, and I think the worst thing we can do is force people that are doing everything right to go through the indignity of suspicion, this constant stigma around, you need a little bit of help because your job doesn't pay enough. We're gonna make you go through even more work just to demonstrate a little bit of assistance. So, thank you.
Thank you.
Thank the gentleman. Representative DeVanzo.
Thank you, Chairman Harris. And Madam Secretary, thanks for coming back. I have a situation in my district that's confusing, so I'm going to do my best to explain it. There's a lot of acronyms in here. So.
Oh boy, that's never good.
So one situation I have is a mother received a notice her daughter's room and board in a group home would increase by 50%. It would go from $712 a month to $1,479 a month. The provider was trying to use the room and board to recoup some of the funds because their daughter is receiving services through the OLTO. Okay, the residents receiving services under the ODP, they only saw a $7 increase. DHS is planning to get involved with this a little bit. We've been dealing with this since December. I understand there's a difference in the ODP and the OLTO, but the ODP rates are reviewed regularly. And my concern is that the low OLTL rates are causing situations such as one as my constituent is experiencing. How can we plan to address these issues to ensure that both groups are receiving the they're both being treated fairly?
Yeah. Well, first of all, we would be happy to work with you on your constituents' issue. It's hard for me to parse it out, without knowing more details, but certainly please, circle back with my team and we'll be happy to get into it and see if we can help sort out what's going on there. But to your larger question, I think that, again, there has been a historic way of approaching these rate determinations here in the Commonwealth where they're done periodically. And I think that for the stability of the Commonwealth's budget and for the stability of our providers and the stability of the workforce in these systems, that a system that just looked at regular, yearly, incremental, sort of cost of living type of approach would be a win-win all the way around. There's many things that would have to happen to go from where we are today to that, but but they're certainly not insurmountable, and it's something that I would be very interested in exploring with the General Assembly if you're interested.
Yeah, no, definitely. And if I looked at some of this right, the Office of the OLTO, the governor's proposal this year would be $6.7 billion would be their budget proposal. And the OLTO is run by an MCO, Community Health Choice. And they're set to make, and they're allowed to make a 3% profit. But, you know, their profit this year would be $202 million. And it's just, it's concerning, it's alarming that we're taking taxpayer dollars, giving it to the OLTL, and I get how business works, but my constituents are somewhat being squeezed here. That's how we feel.
So Community Health Choices is actually consists of 3 managed care organizations that provide services to a specific but very large group of Pennsylvanians who are older adults, who are Medicaid and Medicare eligible. They're, you know, very low income individuals, and they have the opportunity to receive services in the community or in a nursing facility. There is a, as we've been discussing, 9.3% rate increase in Community Health Choices. But I do want to acknowledge, and I neglected to remind Representative Nelson of this, and perhaps, Mr. Chairman, you could remind him of this for me. Oh, you are still here? Oh, I'm sorry, I didn't see you. I'm glad you moved, right? Or am I just imagining that? $1.16 billion of the rate that's included in the rates for this year are changes in the nursing facility reimbursements that the General Assembly has approved. So just as a quick reminder on that, in January of 2023, there was a legislated 17.5% increase to nursing facilities, and then another 7% nursing facility rate increase effective this January of 2025. So in total, that's $1.16 billion included in the rates for changes in that CHC budget. That is a big chunk, also in addition to the other things that we talked about, Representative, of why that CHC budget is going up so much.
All right, perfect. Appreciate your answers. Thank you.
Yeah.
Thank the gentleman, Representative Mays.
Thank you, Chair. Secretary, we've made great strides around uplifting the importance of and the role of doulas, the roles that they play during childbirth. And just for the benefit of educating my colleagues and the public, a doula is a trained professional who provides emotional, physical, and informational support during pregnancy, labor, birth, and postpartum. For Black moms, doulas are one of the great interventions to guard against maternal mortality and morbidity. Because of the work, the longstanding work of Rep. Cephas and the Black Maternal Health Caucus, we passed a bill last term that provides Medicaid coverage for doula services. And this is groundbreaking. It's groundbreaking because we know the importance of accounting for the ways that we have disparate health outcomes, especially if you're a Black mom. Could you just provide us an update on the progress that the Department of Human Services has made on enrolling doulas in the medical assistance program, as well as what are some things that we can do as legislators to help grow the pipelines, grow the opportunities and access for doulas to become certified with the medical assistance program?
Thank you for that question, Representative, and we've been honored to work with you and the entire Black Maternal Health Caucus on this very important issue. I just have to share very briefly, you know, I worked on labor and delivery floors for years. I'm an obstetric anesthesiologist, and I will be the first person to tell you that having a doula on the labor and delivery floor working with an individual patient is a way to make sure that that patient's voice is heard clearly and effectively. We all know that not everybody is heard when they interact with the healthcare system, and having that doula there, I think, is a big piece of why it makes labor and delivery in particular safer for Black women, because it makes sure that their needs are conveyed, that what they're experiencing throughout that process is conveyed and heard. Very, very important piece there. So we are making good progress. We have now got officially in our Medicaid program, the state plan amendment for doulas has been approved, and so they are fully covered in our program. And as of February, just a few days ago, there are 46 unique individuals with 65 service locations in the program. There are 11 groups of one doula each that are in the program now, but they took that group enrollment, I think, hoping to attract others into their group, and we're really excited about that. Awesome. Just a quick reminder that doulas do need to be certified in order to become enrolled in Medicaid, but we've worked with the Pennsylvania Doula Association to make sure that that certification can be done at no cost.
Great. And so before that, there was a huge gap in the ability for someone who was a doula to be able to enroll in Medicaid, because we needed both. We needed the legislation to say, we want Medicaid to cover doula health services, but we also needed the pipelines of doulas and the education around certification to be able to put them on the right track to enroll. And so again, this has been years and years and years in the making. We're so excited at the progress. And I do want to reiterate, what else can we do as legislators? How else can we attract more doulas? Because we know the need is great, both on Medicaid and private insurance, sure. In hospitals, at birth centers, et cetera. How can we help grow the pipeline? Because this need is great, and we know that it is a proven intervention.
Yeah. You know, I think continuing to do what you're doing to publicize it, to make sure people understand what a rewarding career this can be for folks and what essential services doulas are providing. I think once people understand what it is, you know, the part of the problem maybe is the name. People hear doula and they don't actually know what that is. So I think there's a lot of education and public awareness that needs to happen, but we do find that once people understand what it is and become doulas, it is their life's work. They are passionate about it, and we're so happy that we can make sure that when they're caring for someone in our Medicaid system that they can be paid.
Thank you. And last thing, as my time comes to a close, we're noticing that for doulas, they generally have, in the past at least, and probably in the present, they've considered it as part-time work. Do you think the opportunity to enroll in the MA program for reimbursement will help it to become a full-time living wage career over a person's lifetime? I know that a lot of doulas I've encountered, they've just been part-time, and some people prefer it that way. But I think how can we grow the career of being a doula in this Commonwealth?
Yeah, I sure hope so. I don't actually know if all commercial plans cover doulas. I know many people private pay for doulas. And so, you know, I think looking at that might be of interest to see if commercial plans also cover doulas. I just don't know. It might be a question for Commissioner Humphreys. We were very mindful in setting the rates in the Medicaid program, at least on the fee-for-service side. You know, obviously MCOs always end up negotiating, you know, separately from that. But at least on the fee-for-service side, we did set a rate that we felt was competitive with our understanding of what was being paid in the private sector. So, you know, hopefully the answer to your question is if that's what somebody wanted to do, that they would be able to afford to do it.
Thank you, Secretary.
Thanks, the gentlelady. Representative Curry.
Thank you, Chairman. Hello again. I just wanted to talk about the fact that I was so excited to hear Governor Shapiro talk about his plans to increase the development of care for women who go through postpartum depression after they have a baby. We know that last session we enacted legislation that was Act 102 in 2024 that would help educate, which was on the Momnibus, I just want to say that, which would help to educate individuals about postpartum depression. But much more can be done. And that's why I was so excited to hear the governor's plan to push that forward. We know that the postpartum period can be a very challenging time, but I just want to give statistics so others can understand that a lot of women go through it, 15 to 20% of new moms. But when we talk about the Black Maternal Health Caucus, we know that 25 to 40% of new Black mothers have postpartum depression. So here's the push. We know that it's important that individuals understand and they can ask for help. A lot of this comes with many things that happen during the pregnancy or after the pregnancy, but what services are available to individuals through the department to help offer services and supports to help these moms understand the symptoms of postpartum? Because a lot of times after birth, you're sitting around, you're like, am I feeling crazy? I can say it because I've had 3. What's going on, right? And we know that there's things that are much more intense, like postpartum psychosis, that we don't often talk about, but that definitely attacks women after they give birth. So how are you working with the Department of Health to address these conditions like postpartum and maternal health?
Yeah, thank you for raising that issue. And just the fact that you're here talking about it publicly is part of the answer. I sat on the Maternal Mortality Review Committee from its inception in 2018 until 2023, when I had to step off when I became secretary. And as you know, more than 50% of our maternal deaths are postpartum, and quite a number of them were related to behavioral health types of conditions, one of which was unrecognized postpartum depression or untreated. It could be either. Yeah. I think we need to do a couple of things. One is we must dramatically reduce the stigma around this issue. You know, there's this narrative out there that everyone should be so happy, you had a baby, everything's wonderful, life is great. But that is not necessarily the reality for, as you pointed out, maybe as many as a quarter of new parents. And we need to destigmatize that it's okay to ask for help. And that it's, you know, people are feeling a lot of things when they just had kids.
Right, and I think the same is for partners and fathers.
Yes.
I mean, they don't know what's going on either, so.
And neither do a lot of medical professionals.
Right.
That's going to be my next point. So we need to educate there. We are working through the Maternal Health Strategic Plan to come up with some very tangible recommendations around some of these things. There's this new app called Mayama that we've developed. I think you're familiar with it. That can be a resource for new parents and pregnant moms. So we have a lot of things in the works that I hope will destigmatize and make it easier for folks to get connected to treatment.
Wonderful, thank you very much. And the last question that I have is, pregnant women are sometimes challenged by substance abuse issues and requires substance use disorder treatment prior to and after delivery to help improve health outcomes for both mom and baby. What are some of the ways that DHS is helping these women to gain access to the treatment they need both before and after they have their baby? And how are you helping these women to remain sober and manage their health through the postpartum period and beyond if they need additional care?
So you may be familiar with Plans of Safe Care. Plans of Safe Care is a voluntary effort for new parents whose babies are born substance affected, and we are making sure that, so let me take a step back. Plans of Safe Care has been available all across the Commonwealth for a while now. It hasn't necessarily been the most robust of our programs to help families. So we have, there's been a lot of work done around this. There's a lot of support for making Plans of Safe Care more robust. We recently applied for and were able to receive a $2.5 million award for technical assistance to work with a whole host of stakeholders on this to make Plans of Safe Care much more robust. So the idea would be that at birth, if an infant was identified as substance affected, that family would be offered supports and services. It is not a report to there's a requirement for a reporting to Childline, but it doesn't go in as an abuse report. It's a separate sort of pathway. And the hopes would be that by making this plan or these efforts much more robust, that we can help a lot more families be successful.
Thank you very much. I look forward to working on that more with you. And thank you, Chairman.
Thank you.
Thank the gentlelady, Representative Madsen.
Thank you, Chairman. Good to see you again, Madam Secretary. For a follow-up question, mine's pretty straightforward. Can you provide an update on the elimination of the four walls rules from CMS?
Yes, I would be happy to do that. So for those of you who have not been following this one closely, during the COVID-19 pandemic, all of the regulatory requirements around telehealth to deliver behavioral health services were lifted, very successfully, I would add. People were able to partake of telehealth, behavioral health services in, very comfortable ways from their homes. It was done very successfully. When the public health emergency ended, CMS reverted back to their original rules and regulations, one of which is not so affectionately known as the 4 walls requirement. And it requires that either the patient or the provider be located in a clinic, that's the 4 walls, in order to bill for those services. So one or the other can be somewhere via telehealth, but one of them has to be in a clinic or an enrolled site of service. So obviously this has caused some issues for folks. Happily, CMS in November released a new final rule where they didn't eliminate the 4 walls requirement, but they did establish a pathway by which a state could apply for a plan amendment that would relieve that 4 walls requirement. We are in the process of applying for that. We were anticipating that this rule change might come, so we got to work immediately once it did. And hopefully sometime within the next 6 months to a year, we will be able to relieve that 4 walls requirement.
Thank you for that very thorough answer.
More than you wanted, probably, but it's been top of mind for a while now.
Thank the gentleman. Representative Salisbury.
Thank you, Chairman. My question this afternoon relates to families that have medically fragile children at home. And I know that we've talked a lot today about nursing shortage and overall caretaking shortage. I wonder if you can talk a little bit about what DHS is doing to help some of these families keep their children at home with them and not have to send them to be cared for at some other location that might have more staffing options.
Yeah. So, this is another interesting evolution that COVID to some degree has triggered. During COVID, those families couldn't get nurses to come into their homes. And so parents really stepped up, very much by necessity, but they really stepped up and they continued to take care of their children in very strong and robust ways. So again, with the end of the pandemic, we've gone back to a lot of the kind of normal, traditional rules and regulations that are required. We are very interested in finding ways to make sure that parents can be supported and also that nurses are getting reimbursed appropriately for coming into homes to doing this work. So there's sort of 2 things in play. One is that we are in regular communication with many of the nurses that do this work and keeping a mindful eye on rates that are paid in that space. And at the same time, we are working with parents and looking at ways that they could be paid through this system a little bit more easily. It would require that a statutory change that would change the way that nursing delegation the delegation of nursing services can be done.
So that would be a role for the legislature?
Yes, there's definitely a role for the legislature. Right now, the nursing board doesn't do that, but there is actually, I think, proposed legislation that would affect that change.
And I'm curious about how these rates are determined. You talked about appropriately compensating the nurses who do this work. Can you talk a little bit about how that gets calculated?
Yeah. So that is more of a market-based approach in terms of how that's done and, again, becomes part of the appropriation for any given year.
Do you have any information for me on, we talked earlier in the morning about when some people need different levels of care. And so some people are able to have the care professionals come in, but they are not nurses. And then some people get to the point where they might need a more skilled person who has more training, who has more education and has more medical knowledge. Do you know where that tipping point is where families might need to bring in a nurse rather than a different type of professional?
Yeah. It would have to do with the needs, the assessment of the needs of that particular child. I can't recite them to you off the top of my head, but that is pretty codified in terms of when needs meet a new level of expertise in terms of treating that. One of the things that we have done is set up pediatric resource centers for families. There's a couple different regions around the state where they're located, but they serve the entire state. And it's a kind of a one-stop shop for families with children like this, where they can get all sorts of resources for how to approach the in-home care of kids like this with very complex needs. You know, some are on ventilators, you know, these are really tend to be very complex kids.
And from speaking to people in my district, we've had people contact us for all different types of things. I remember we had someone contact us on a Friday afternoon because her power was scheduled to be shut off. And she did have a medically fragile child at home, and she was terrified because equipment might be turned off, and you just never know. Sometimes you have to keep certain medications cold, and now your refrigerator is going to warm up. Are there any resources for where we can send constituents perhaps to your department, or there are other resources that we could direct them if they have an emergency like that for a child at home?
So in a true emergency like that, the first place to go is to their electricity service provider. They do all have emergency medical waivers for a situation like that. So the first job is to make sure the lights stay on, right? The electricity keeps coming.
Fortunately, they were kind to us in that situation. We were able to sort it out, yeah.
That's good. And then, of course, we have our LIHEAP program, which can, if it really, that is a heating program, so it would depend on how they got their heat. But if their heat was electric and it was winter, they may be able to apply for an emergency allotment through LIHEAP. But if it's, you know, it's tricky in those situations. I think primarily the place to start is with their electricity provider, who they do have capacity, and they do have community programs for individuals who are not able to pay their bills.
Thank you very much. I see my time has elapsed, so thank you very much for your information, and thank you for all of your work all day. It's been a long day for you, I'm sure.
Thank you.
Thank the gentlelady, Chairman Struzzi.
Thank you, Chairman Harris, and thank you, Madam Secretary, and your team for staying with us. I want to revisit one of the first questions that were asked this morning from Representative Coots on your 24-25 supplemental. I think we're asking for a little bit more clarity there, and that you did say that prior year funds were used to offset some of those costs, and I want to make sure we have the numbers before us moving forward into this budget discussion. But can you share the exact number of your fiscal year 24-25 supplemental need, and then how much of your prior year funds were used to offset this amount and result in the net supplemental request of $251 million?
Sure. I'm going to let Gloria get into the details of that, but I just want to say this is a normal process that's done across multiple
Sure.
state
Yeah, I
agencies,
understand that. I just want to make sure we have the correct numbers. Yep.
Yeah, and I should clarify, like, I don't know that we said that we used prior year balances to reduce a supplemental need. What I said was there's a process by which you can request a waiver to hold prior year funds for expenses that should have been attributed to the prior fiscal year. So we did use prior year funds for expenses that were attributable to fiscal year 23-24, and then we accounted for that need as we moved forward. There are also
Can you get us those numbers? That's what I'm asking for.
They're actually spelled out in the budget materials. You actually have them. But if you want me to break them out in like a spreadsheet, sure, we can do that.
I'm sure we can find them, but I think it would be easier if you just provide them to us, you know. There's a big budget book there.
It is a big book.
And a lot of numbers.
I like people to read it because we put a lot of time into it.
Yeah, we'd appreciate that exact amount of the supplemental, and then, you know, what prior year funds were used, if you could provide that for us specifically. So, looking at the numbers, and first I want to preface by saying I truly appreciate what your department does. I was on the Human Services Committee every year that I've been in office up until this year. I've had a number of pieces of legislation designed to address some of the issues that we've been discussing here today, and I understand the important role Human Services play in our communities, for our families, for our young people, for our elderly people, but I think we have a fundamental math problem with this budget. So looking at the Medicare, or the Medicaid amounts that we essentially have to cover. And as I said at the beginning, there's a $1.9, almost $2 billion increase in the proposed budget, and that's mainly due to those rates. Just $660 million for capitation and roughly $940 million for community health choices. We have to pay for those, correct?
Yes. Those
Okay.
are considered entitlement
And so
programs.
looking at the budget proposal, the governor, his expected revenues for the upcoming year are only roughly between $1.4 billion and $1.6 billion. So essentially, the expected revenues for the next fiscal year are wiped out by the need to cover these Medicaid costs. So that, to me, again, creates a fundamental math problem for the budget. And then on top of that, your proposal spends for new initiatives roughly about $150 million. And then the governor on top of that is spending another $1.5 billion in new expenditures. And if you take all the other new taxes that he's proposing off the table, we're still just going to break even if we cover the Medicaid costs. So that's really a concern for me, and I think it's something that, as we move forward in these budget discussions, we're really going to have to take into account. But I want to ask, given that consideration, throughout the year, your department issues various medical assistance bulletins announcing new services or providers in the medical assistance program. Do you anticipate adding any new providers or services in fiscal year 25-26?
Possibly. We're, as you've heard earlier, we are looking at the possibility of adding community health workers. We are continuing to work through the way that certified recovery specialists are used. We're very much hoping to implement the 1115 waiver just for the reentry services, which should have a very positive impact on recidivism and overdose deaths and the way that reentrants access medical services in our Commonwealth by going to, being able to go to a primary care doctor instead of an ED, which ultimately saves money.
So those would have to be legislatively allocated. You would need legislation to move forward with those?
Well, the 1115, we would definitely.
Okay, and so that could potentially...
If we add another category of providers, not necessarily. But I do think, it's really important, Chairman, to note that in the rates this year, and I will be the first person to tell you, and I'm sure hopefully you read my budget testimony, this is an atypical year for us.
Right.
And there's a couple of things that really jump out. One is, and I'm not saying that these weren't justified, but I just think it's important on the record to say these things out loud, that ambulance rate increase that was authorized by the General Assembly this year adds $160 million. We talked about GLP-1s earlier, and we're taking a hard look at it. That's under our control. We're taking a hard look at it. Dental fee, very minor, but $24 million nonetheless. We talked about the nursing facility increases that were legislated. We didn't ask for those increases. Just last year, 7%. And with those 2 years of increases, it's $1.16 billion. The personal assistance services that we've talked about at length today, that is 8%. But I do want to point out that that is the most cost-effective way to take care of our seniors. It keeps them out of nursing facilities, which, as you know, lead to huge increases in this program. And so I don't want the narrative to be here that we're doing something that is not very mindful of taxpayer dollars. There's just a lot of competing interests here, a lot of providers who are asking for increase in rates. And this is the reality that we're facing together.
You are essentially making my point. Thank you. You yourself said this is a very tight budget year.
Yes.
And as I said, there are services that are essential within human services that we have to provide for, but we have to budget for those. And so we find ourselves going into this budget already in the hole by $1.6 billion. And by no fault of your own, because a lot of these do come through legislation, we have to be prepared to account for those. And then spending on top of that is, I think, where we have to maintain some level of control, because we have to balance this budget, by June 30th constitutionally. And given these kind of numbers and the kind of proposed spending that's in front of us in the governor's overall proposal, it's going to be very difficult to do that and continue to talk about spending on new initiatives, not just in your department, but across the board. And we've heard over these past 2.5 weeks, just spend, spend, spend. And I think we need to exercise some level of responsibility, because what your department does is essential to our communities. and we need to provide for those services. But as you said continuously throughout this morning, or this entire day, we need to be responsible with taxpayer dollars.
And I would share just that some of the things that we're proposing in our programs, which, and believe me, as you know, there are a lot of things that we took off the list, which has been very difficult. We are proposing things that we have evidence will reduce the rate of increase in our Medicaid programs. I mentioned several hours ago that historically our rate of increase has been 1.9% in the Medicaid program, year over year approximately. The national increase tends to run about 3%. I'm really proud of how this program has done. One of the biggest things that we do is we hold these managed care organizations. They are 100% at risk. They're fully capitated, 100% at risk. But the things that we're proposing, like the reentry program, are designed to keep that rate of spending as low as possible. So I just want to put that context in. We're not just adding these things on to add them on.
I understand.
We're adding them on with a purpose.
Sure, and I 100% appreciate that. Just one more quick question. The SNAP benefit cards and all the stuff that were discussed, theft as you put it, why are we not, or maybe we are, but you haven't mentioned it, why are we not pursuing the chip-enabled cards?
Yeah, that's a great question. So the chip-enabled technology is only recently become available to states. We talked briefly about the fact that the Food and Nutrition Services, which is part of AG, the U.S. Department of Agriculture, not our AG, picks vendors. There's 2, and they've only recently enabled this technology. There will be a state cost to the chip-enabled cards. The federal dollars will cover half the cost. We believe the state share will be about $7 million to switch over to these chipped cards. We would love to be in a position to do that. A part of the reason why you didn't see it as a budget initiative yet is because we have seen 2 states that have already begun implementation, and they have had some IT problems on the back end.
Okay.
So we want to make sure that when we come to you and say, okay, we're ready now, like it's going to work and we're not going to have problems. That this is something that we very much want to do. It's not quite ready yet.
Well, I appreciate that.
I wish it was, because I'd be in line.
Well, I mean, based on what we heard today, I mean, I couldn't even imagine relying on these benefits and then finding out at 12:01 a.m. that they're gone and you have no chance to get them back and provide for your family. So I think that's very important that we do everything we can to help these individuals and this program to prevent theft. So thank you all for being here. Thank you, Mr. Chairman.
Thank you, gentlemen. Madam Secretary, we thank you so much for being here. I have just a couple questions for you. How many people in Pennsylvania are currently on Medicaid?
Our most recent numbers are 2,994,014, and that was as of December.
So about 3 million people?
Yes.
About 3 million people. Who are those people? I think for the benefit of folks who might be watching, folks who don't know, I think we talk about Medicaid. I don't think folks have a full understanding of the profile of the folks that we're actually talking about. Who are those folks on Medicaid?
Well, 1.3 million of them are children. So really a little over a third of the population are children. 312,000 are older adults, meaning that they're 65 years of age or older, and so low income that not only, they get Medicare because they're over 65, but they're so low income, they also qualify for Medicaid. And then in terms of working age adults that are non-disabled, it's about 1 million.
Okay.
Many of them are working.
So about 300,000 seniors, 1.3 million are our children, correct?
Yeah.
Where do they live?
I'm sorry?
Where do they live?
Oh, they live everywhere. In every county in the Commonwealth. We shared with all of you individual district data about who is in your district. Hopefully you got your sheet. Is in Medicaid, in SNAP, and receiving those benefits. Many individuals are in our rural counties. Very high rates of Medicaid use in our rural counties.
I'm sorry, I didn't hear that. Very high. So can you speak into the mic?
I'm sorry. Very high rates of use of Medicaid enrollment in our rural counties.
So very high rates of Medicaid users in our rural counties.
Yep.
Okay. I heard a statistic that 45 counties in the state of Pennsylvania had a population of 20% of their people on Medicaid?
Oh, I'm sure it's at least that, because 23% of Pennsylvanians get their health care through Medicaid. 23% of Pennsylvanians.
So it's about 1 in 5?
Yeah,
Okay. So 1 in 5 Pennsylvanians get their health care from Medicaid?
like closer to 1 in 4.
Okay, so closer to 1 in 4. Okay. So close to 1 in 4 get their health care from Medicaid, right? Around 1 in 5 people in 45 of our counties would have been on Medicaid as well, right?
At least, yeah,
Okay.
at least.
So understanding the population that we're talking about, 1 in 4 people getting their health care in Pennsylvania from Medicaid, 1 in 5 people who live in on those 45 counties are on Medicaid. Tell me what the Trump cuts of $880 billion would do to Medicaid's budget in Pennsylvania and to that 1 in 4 and 1 in 5 population.
It would be devastating. It depends on how those cuts come down. There could be different ways that they structure it, but the bottom line is there would be many more uninsured individuals. There would be many people who still had Medicaid, but with far less benefits, and not only would those individuals bear the brunt of it personally and their families, there'd be a lot of children potentially that no longer had access to health care, and of course our hospitals, who are required to treat people in an emergency, would see an enormous increase in uncompensated care in their emergency rooms.
Now, Secretary, you're a doctor, correct? Okay. So you are very well aware of the hospital crisis that we have here in Pennsylvania, not necessarily in Philadelphia County, but in rural parts of Pennsylvania. We have a shortage of care in many rural parts of Pennsylvania. So based off of your testimony, if those cuts were enacted and those folks were not on Medicaid and getting that health care, the hospitals would then have to still service those folks but not be paid for them.
Correct.
Right?
It would be devastating. If you look at we've talked a little bit about rural health this morning and the priority that this has been for the governor and this administration. If you look at the hospitals that are in counties class 4 through 8, about half of them have negative profit margins, and the other half have positive profit margins. But let me be clear, we're talking about like 0.5% or 2% or 2.5% positive margins. You know, a good hospital maybe has a 4% positive margin. These hospitals are doing okay, but they can't tolerate any sort of increase in uncompensated care. And for the other half that are already with negative margins, they have no capacity to absorb uncompensated care.
So if these cuts were to come down from the federal government, these folks are now no longer, may not have any Medicaid coverage. They go to those hospitals in those, counties 4 through 8, some of our most rural, poorest counties. What would happen to those hospitals that are on the margin if they would then be forced to provide service that they couldn't get reimbursed for?
So under the law, if an individual shows up in an emergency, heart attack, car accident, in labor, whole number of things, they are required to care for that individual. And so that would be just uncompensated care that they would have to eat. We know from 2015, when Pennsylvania expanded Medicaid and brought 750,000 people into the Medicaid rolls, we have reduced uncompensated care for our hospitals by 27.7%. And that includes the fact that prices have been rising. It takes that into account. We've reduced that uncompensated care by almost 30% since 2015, which is extraordinary. All of that would go away.
So let me ask you this. Would it be fair to say that many of those hospitals and/or health systems over a short period of time may be forced to either cut back on services or close if the number of uncompensated visits they were seeing were to drastically increase because people weren't on Medicaid?
Yes, I think it's fair to say they would have to either cut back on services, reduce their services, and in some cases they would likely close.
So if they would close, then that would mean that many of our citizens in rural Pennsylvania would find themselves in a place where if they got sick, they would not have a hospital to go to.
Right, and that's already the case because some rural hospitals have already closed. And so there are many counties where people have to drive an hour or so to get to a hospital, that would only worsen.
So it would seem that those proposed cuts could be drastic and dire to those who live in rural Pennsylvania with regards to their health care coverage.
Absolutely.
Okay, thank you. Switching over to childcare real quick. Do you guys know how many of our childcare workers make under the minimum wage?
I don't know if we have the exact number, but it's a considerable number. I think it's, I don't know if it's the majority, it may be close to the majority.
Okay, so.
We can, I think, get you a better estimate. I just don't have that exact number in front of me.
So then that would mean that a considerable amount of our childcare workers would see a pay increase.
Yes.
Should Pennsylvania pass the minimum wage.
Yeah.
Right. So those childcare workers that make under minimum wage, do many of them also receive services from DHS for themselves?
Yes, they do.
Okay.
They qualify for Medicaid. Yes.
So if minimum wage was passed, many of those folks would see an increase, right, in their wages. Some of them would see an increase and then would not necessarily need services from DHS, correct?
Yeah, at this point, even $15 an hour at 40 hours a week still qualifies you for Medicaid. So it wouldn't necessarily remove all of them from Medicaid, but sometimes if, there's somebody who's now making 16 or 17, if the floor goes to 15, maybe they get up to, 18 or 19, then you would start to see some folks that would no longer be eligible for benefits. But we are at a place, we're so far behind in this state in terms of our minimum wage that even $15 an hour qualifies you for Medicaid at 40 hours a week.
So wait, so let's talk about that one quick thing. So if we pass the minimum wage tomorrow and everybody's making $15 an hour, you're saying that people would still be so financially strapped that they would still qualify for Medicaid?
They would be.
Wow, that's interesting.
$15 an hour is not a living wage. I'm sure you're very familiar with that idea of a living wage, something that would allow you to pay rent, and rent that is less than 30 or no more than 30% of your income, and still have money for food and other things. $15 an hour, a full-time job at $15 an hour still qualifies you for Medicaid, and it's not a living wage.
That is crazy that some of the folks taking care of our most precious resource, our children, can't even afford to take care of themselves and have to find themselves still on government assistance. But you would believe, based off of what some folks say, that these are folks who are staying home. They're not staying home. They're actually taking care of our children, correct?
That's correct.
So they would be very valuable to the economy of Pennsylvania, because if they weren't taking care of our children, then their parents may not be able to get to work.
Child care is essential for our economy. It is the crux of our economy. If parents can't afford child care and have a place for their children to work, then they can't work. And every parent wants to know that their child is safe, somewhere safe and thriving, so they can concentrate on their job. These child care workers are essential to our economy.
One other area that I'm very concerned about that's a part of your budget, direct care workers. Do you know how many of those direct care workers are making under the $15 minimum wage?
A majority.
So you would say a majority?
In the direct care, not the direct service provider, the DSPs that work with the intellectual disability community, they're making more. But many direct care workers and community health choices are making less than $15 an hour.
Correct.
Or right around. It depends on the region of the state. Some are making right around 15.
Now, correct me if I'm wrong. These are the folks who are providing in-home type of services for grandma, making sure she eats, making sure grandpa takes his medicine, making sure that those folks stay in their home and not end up in a hospital or a skilled nursing facility, correct?
Correct.
But many of them also make below the minimum wage.
Some just below, but yes.
So if those workers just disappeared because they could make more money, let's say working at Chick-fil-A, right? Would you say that in the grand scheme of things, Pennsylvania will see an increase in our DHS budget because many of those folks who they're taking care of in the home would be transferred to a skilled nursing facility or find themselves in a hospital?
Correct. So by definition, if you qualify for home and community-based services, it means that you have conditions that would qualify you to be in a nursing home. And nursing homes are an entitlement. The services that we offer in the community are actually offered under what's called a waiver. And we do that because home and community-based services, as we've mentioned today, are more cost-effective than the cost of a nursing facility. And so if, you know, wave a wand and home and community-based workers went away, those direct care workers went away, then we would be required, because nursing facility care is an entitlement, to move all of those individuals into a nursing facility at a higher cost than what we're paying for them to stay in the community, which of course is where they want to stay.
So, should the federal government move forward with the proposed $880 billion cuts, according to what we've talked about earlier, we would see, we could possibly see a drastic cut in Medicaid funding at the state level and our ability to provide that service for people, correct?
That's correct.
Okay. So if those cuts happen, then that means that many of those people would no longer have Medicaid coverage, which means that the hospitals and doctors' offices that they go to would not be reimbursed for their services, correct?
Correct.
Many of those places are in rural parts of Pennsylvania that already have a shortage of hospitals and health care in those areas, and those hospitals would therefore be overburdened with folks who they're not going to get reimbursed for, correct?
Correct.
Would you also agree that that would mean that many of those hospitals and healthcare centers would probably in a few years find themselves maybe either limiting their services or closing their services?
Yes.
Okay. In addition to that, should those cuts come down from Washington, D.C., the $880 billion proposed Trump cuts, would that have an effect on our child care workers and our child care providers and our ability to pay for those services as well?
Well, it would have an effect on the individuals who were Medicaid enrollees. They could potentially lose their Medicaid. Our funding that pays them is a different line, not tied to Medicaid.
So those parents, those direct care, service providers, as in like the child care workers, they themselves could lose health care coverage, and their children could possibly also lose health care coverage, correct? So that means now that child that gets sick can't go to the doctor, so mommy or daddy would probably have to stay home and take care of them. So I say all this to say, I mean, it is very clear that should these cuts happen, it would be drastic for our Medicaid population, which, according to what you said, is 3 million Pennsylvanians, correct?
It will be catastrophic.
Catastrophic for the 3 million people. I would say, so catastrophic to the 3 million people, but it would probably be, we probably wouldn't recover in rural Pennsylvania because many of those healthcare providers and hospitals would close because they would have to provide services by law to folks who no longer have healthcare coverage, correct?
Yeah. It would take a situation that is already very difficult from a budget standpoint for rural hospitals and make it much worse.
So it is clear that nobody who represents or says that they care about rural hospitals could support the $880 billion in possible cuts to Medicaid.
Certainly not here in Pennsylvania.
Thank you so much, Madam Secretary.
Thank you, Mr. Chairman.
Thank you all for being with us for, what was it, 5.5 hours now for our DHS budget hearings. Thank you to the Secretary. Thank you to this whole staff for all of the work that you do for our most vulnerable populations all across Pennsylvania. Sister Shantae, I didn't forget about you. I was going to ask my question, but I'm going to let you live today. I got you, all right? I appreciate what you do, too. I'm just saying, she worked with me with all of our child care providers back home. We love the work that you do as well. We appreciate you. All right? I got you. We will be back here tomorrow morning at 10 o'clock where we will be with the Department of Insurance. 10 o'clock here. This committee hearing is adjourned.